I'd like to take this opportunity to welcome all of you and apologize for what appears to be a late start, but we were just waiting on others to join. As you're aware, or might not be aware, this symposium started back in 2010 under the instrumentality of Dr. Mills and Stacy Daly, as well as Roche Chemicals, Pharmaceuticals rather, and Michelle Brown. The idea was more information needed to be provided to the Jamaican public on this matter of the health of our colon. And there has been many such symposiums. Some have been held at the North Sud Court Hotel, as well as in Montego Bay and other areas. So um, this has been going on for 10 years, as you would recognize. With us this morning is the chairman of the Jamaica Cancer Society, Mr. Earl Jarrett, and he will be making some opening remarks. As you know, Mr. Jarrett is not only the chairman of Jamaica Cancer Society, he is the CEO of JN, a very accomplished gentleman, a very affable person, and we ask him now to come forward and say a few words in terms of opening remarks.
Thank you, Mr. Moderator, Mr. Milton Sylvester, Mr. Michael Leslie, Acting Executive Director of the Jamaica Cancer Society, Mrs. Deborah Chen, Executive Director of the Heart Foundation of Jamaica, special guests, presenter, Dr. Catherine Hagen, Senior Associate Consultant Pathologist from the Mayo Clinic in Rochester, members of the Cancer Society, members of the panel of presenters here today, distinguished persons all, members of the medical community, welcome to the Colon Cancer Medical Symposium, being presented by the Jamaica Cancer Society, the Heart Foundation of Jamaica, the Association of West Indies Gastroenterologist, and Apex Radiology. The past year has been a challenging one for persons in the healthcare industry, as the COVID virus has disrupted our activities to be proactive in reducing the burden of preventable or controllable diseases on the people of Jamaica and the world. The pandemic has affected our organization and many others in a very similar way. The Jamaica Cancer Society and the Heart Foundation was affected in the following ways. We were unable to provide the level of service that was due to the fact that for the first 3 months of the past year, our activities were curtailed in keeping with the international health protocols. We subsequently opened, but could only offer limited services and could not offer the normal outreach services. As a consequence of the offerings being limited, the staff made significant sacrifices, some salary sacrifices and others even more so, to keep the societies going and keep charity alive and well in Jamaica. The Jamaican economy was impacted severely, with the GDP being reduced by up to 18%. Tourism, which is a mainstay of the economy, was reduced by over 70%, which meant that our committed funders were unable to offer their usual financial support. The Cancer Society and Heart Foundation were therefore also unable to stage the usual fundraising activities, and for the period we must thank the companies and individuals who provided a financial lifeline to the organizations. COVID has had a serious effect on the health of the population. As we all know, many hospitals were overcrowded and many elective surgeries had to be postponed or not done at all, as the hospitals had to cope with the increasing numbers who turned up for intensive care and treatment. Of course, there seems to be a light at the end of the tunnel. Not seems to be, there is a light at the end of the tunnel. And that just last week, Jamaica began to provide vaccinations for a limited number of persons. The Ministry of Health has been rolling out its vaccination plans. And thanks to the government of India, we got our first 55,000 doses of the vaccine in Jamaica. And this signals that the end of this COVID nightmare may be ending. and maybe insight. I invite you all to find ways to support the Jamaica Cancer Society and the Heart Foundation as we cope with the financial challenges caused by the COVID pandemic. Today, we shall focus on colon cancer. Uh, and today's program will give you an opportunity to get comprehensive information on colon cancer and colorectal cancers. Your presenters will provide information on the state of the colon cancer in Jamaica, how it can be diagnosed, the approaches to treat colon cancer, and importantly for the public, how it can be detected and indeed prevented. Our special guest presenter will explore the genetic factors that may impact or make some of our persons in Jamaica predisposed to colon cancer. I look forward to hearing about that. Some persons may have genetic, well, we learned today whether the genetic factors play a role in colon cancer. I invite you all from around the world. I know we have Jamaicans online from Canada, the United States, and friends from those areas who have joined us today. And I hope today we'll all open our minds to receive the information which is being presented. And I trust that it will be beneficial to you and that the Cancer Society and the Heart Foundation, by doing this symposium, and the Association of Gastroenterologists, will be doing an important job in public education and public health learning in Jamaica. With that said, Mr. Moderator, I hand back to you.
Thank you so much, Mr. Jarrett. Really appreciated that. So without further ado, we will be going to our first presentation. I was warned not to get into too much, so I take this opportunity to introduce Professor Joseph Plummer, Head of Department of Surgery, Radiology, Anaesthesia, and Intensive Care at UWI, and he will be presenting to us Colon Cancer in Jamaica 2020. What is the story?
Good morning, ladies and gentlemen. Let me say thanks, Mr. Moderator, for giving me your introduction, and thanks also to the Jamaica Cancer Society for once again another invitation and an opportunity to speak on colorectal cancer in Jamaica. And this morning's topic is colorectal cancer. What in Jamaica? What's the story? So I will use an opportunity to really share with the audience somewhat of a story or the current story of colorectal cancer in Jamaica. I will say that I have no disclosures, and I'll start off with a little bit of data that I'm sure some of the audience know, but I don't think it will hurt reminding us that colorectal cancer is the third leading cancer in both male and females in Jamaica and the region, and in fact in most Western countries, and depending on the literature, it could be the second or the third leading cause of cancer-related deaths. So in Jamaica, for example, last year we were projected to have somewhere between 500 to 600 new cases of colorectal cancer. But if we should use published data from our experience in colorectal cancer, only about a quarter to a third will be alive and disease-free in 5 years. And importantly, whereas colorectal cancer is decreasing in the United States because of the use of screening, perhaps some additional risk factor modifications such as diet, in Jamaica, it is in fact increasing, and here we think it's a real increase rather than a more widespread use of colonoscopy and other diagnostic modalities to confirm the disease before death. So whereas that may be accounting for some increase, in fact, we think there's also a real increase. And even in the United States, in African Americans or people of African descent, it is in fact increasing, especially in the younger age group, 18 to 45 age. So I'll share the data on two patients I saw in the last 5 to 7 days at the University Hospital. And the first is a 31-year-old woman who essentially gives a history of bright red blood per rectum. In fact, the history goes back as far as 2019, but she has a young child and in fact had hemorrhoidal disease during pregnancy. And when she first noticed the bleeding, she actually thought this was due to hemorrhoids. Though it was mentioned to her doctor in 2020 and a flexible sigmoidoscopy suggested, nothing was done. And that's one of the things that we actually can relate to. A lot of investigations have been delayed for patients because of the whole COVID pandemic. But more recently, she was referred to me with her colonoscopy report. And here it revealed, and I confirmed the mass at about 8 centimeters from the anal verge, and biopsy was of adenocarcinoma. So in planning her preoperative staging, in planning surgery, I sent her for CT chest, abdomen, and pelvis. And this revealed extensive metastatic liver disease. It was rather unfortunate. I've since discussed her at tumor board just about a week ago. And in fact, she's going to start systemic therapy soon. Now, the next patient is a patient who I've scheduled for surgery in another couple of days or so. And here, this 63-year-old woman from central Jamaica presented with constitutional symptoms, and her GP sent her for routine set of blood, the so-called executive profile, and this revealed a hemoglobin of 8.6. So this triggered a colonoscopy, which revealed a cecal mass, histology again, invasive adenocarcinoma, and her CT chest, abdomen, and pelvis was negative for metastatic disease. So she will have a laparoscopic right hemicolectomy. So in Jamaica, colorectal cancer is a disease of the middle age. The mean age of diagnosis is 63, but the fact is we have seen patients as young as age 13 and as old as 99. The most common sites, as in most other countries, these are left-sided cancers. 65% are within the reach of the flexible sigmoidoscope. In fact, the rectum accounts for close to a third of cases, the sigmoid colon, another 25%, and the cecum or ascending colon or right-sided tumors account for about a quarter of cases. Importantly, more than 50% are at least T3, and few or about 10% of our patients actually have T1 disease at the time of their diagnosis. And in fact, only about 1% of patients with an invasive carcinoma are diagnosed by screening. And only 22% of doctors routinely offer their patients or patients in their practice any screening modality for colorectal cancer. So this is something as part of the story for colorectal cancer in Jamaica that needs to be addressed. And here I want to make the important distinction between colorectal cancer prevention versus detection. And we will accept any of the methods. Prevention being removing polyps with flexible sigmoidoscopes or colonoscopies, or detection being testing stool for blood or using CT colonography in addition to the prevention strategies. But other speakers will speak to these. So in our population, we have the usual risk factors: polyps, a personal history, a positive family history, or a history of inflammatory bowel disease. And yes, the so-called westernized diet that is low in fiber, high in red meat, high in processed food, high in fat, are all associated with an increased risk of colorectal cancer. But only about 20% of our patients actually have an identifiable risk factor. And this is why then it speaks to the importance of routine screening of the at-risk patient. And at-risk only means that the patient is alive between age 45 and 50, then it's recommended that they should have a screening colonoscopy. So, as I'm speaking to a mixed audience, I will remind us that these tumors that occur on the right side may present with anemia or a cecal mass or metastatic disease. And in fact, 20 to 30% of our patients actually present with metastatic disease. This is not uncommon, and this gives the patients little chance of being able to cure, and we'd rather it be closer to the 20 than, as we have publications to show, that our prevalence of patients diagnosed with colorectal cancer, actually it's closer to 30%. With metastatic colorectal cancer, it's closer to 30%. With left-sided cancers, the change in bowel habits, the progressive constipation or noticing blood, or some patients will go and actually develop outright large bowel obstruction. Mucus per rectum is not normal. Tenesmus, or this feeling of incomplete evacuation, or sometimes patients, in fact, have partial bowel obstruction and will present with spurious diarrhea. So I'll stop a minute here and to again speak of hematochezia or blood per rectum, because this is common. This should always trigger some invasive investigation of the colorectum. In a young patient, that is one who's under age 40, a flexible sigmoidoscopic evaluation is the minimum that should be done. And this will detect 98% of lesions because it goes up to the splenic flexure, and whatever is causing bright red blood per rectum, 98% of the time is within reach of the flexible sigmoidoscope. But if the patient is over age 40, in fact, it's recommended that these patients should have a full colonoscopy, or if the flexible sigmoidoscopy was normal, then again, these patients should move on to a full colonoscopy. So I'm a surgeon, and the fact is colorectal cancer is a surgical disease, but it's not one that is innocuous, as about 3 to 4% will have post-operative or perioperative mortality. And most of the time, it's not as a result, albeit that yes, this can occur of sudden cardiac or cardiorespiratory death from a myocardial infarction, or pulmonary embolism, or a stroke, but most of the time it's because of anastomotic leaks, which occurs in our population close to 9%. But as you can see from the insert here, that in fact, as high as up to 23% who have had low rectal anastomosis, so colorectal anastomosis deep in the pelvis, especially in a man who has had radiotherapy, may have a leaking complication that puts the patient at risk. And in fact, we take some amount of charge of that risk or reduce this risk by, in addition to making the anastomosis, also diverting the patients proximally. Now, another important thing that we'd like to add to the story of colorectal cancer in Jamaica is ERAS, or Enhanced Recovery After Surgery. And this is a multimodal program that is done in a deliberate way to decrease perioperative morbidity and mortality. In fact, there's good class 1 evidence to say by practicing enhanced recovery after surgery for colorectal cancer, we can reduce postoperative complications, reduce time in hospital, and reduce the risk of death from these patients. So there's 50% reduction in 30-day morbidity and decreased length of stay by 2.5 days. And especially again now, given the pressure on bed space, if you can reduce your length of stay on average 500 patients who require surgery by an average of 2.5 days, you'll see that you're actually creating 1,000 patient bed days in a hospital. And given that the average patient who has surgery spends only about 5 days in hospital, you actually add in space for an additional 200 patients to have surgical care in hospital. So by practicing these ERAS guidelines, and these are preoperative patient education, reduce fasting by giving the patient a high carbohydrate drink up to 4 hours before surgery, decrease the use of mechanical bowel prep, paying particular attention to reducing venous thromboembolism and surgical site infection by the use of prophylactic antibiotics and DVT prophylaxis, avoiding the use of drains such as nasogastric tubes, removing uterine catheters early, or removing intra-abdominal or not inserting them in the first place. Better perioperative and postoperative pain management, and yes, early mobilization, sham feeding with the use of chewing gum. All these are structured interventions that are used in the perioperative period that will enhance the patient's hospital experience and will reduce the physiologic insult on the patient and get the patients home safer after surgery. So what's our survival like? It is not good. And that there's no other way to say it. Using 2 survival curves that were published in the last decade for colorectal cancer in Jamaica, it shows that mean survival, or if we should look at it at 5 years, it's in one publication 33%, and a more recent publication that perhaps is more representative of the Jamaican population, given the larger numbers, 5-year survival was less than 50%. And how does this compare to North America? 5-year survival in North America overall for colorectal cancer is closer to 70%. So in this publication by Dr. Roberts, their overall 5-year survival was 46%. But even in patients with stage 1 or Dukes A colorectal cancer, you'll see that 5-year survival is for Dukes A, 66%, or stage 1, 71%. And these are patients who should be cured with surgery only. So it may be that we're understaging these patients. It may be that they do have positive node and they are not identified as such, and they would have benefited from systemic therapy. And because they were deemed node negative, then they didn't receive the systemic therapy. But whatever is the reason, maybe it's poor quality surgery, whatever is the reason, our survival is less than it should be, and it requires a structured intervention to get the level that we'd like to have. So this is just another way of representing the same data. And the usual factors that are associated with poor survival, for example, patients who have venous invasion or positive circumferential margin or neural invasion, or the number of positive nodes. As the number of positive nodes increase, survival is reduced. So these are actually quite standard, what's expected, nothing new here. I am not saying that we are doing poor surgery in Jamaica, or our pathologists are not as competent compared to North America, because if you should look at the optimal number of nodes removed from this large study that was published in International Journal of Colorectal Disease in 2015, you'll see that in close to 35% of patients, the lymph node yield was in fact less than 12. It doesn't mean that we should be satisfied, but it's also is pointing out that our challenges are in fact similar. Now, another thing that we have added to the story of colorectal cancer in Jamaica is the addition of a multidisciplinary tumor board for the management, not just of colorectal cancer, but for a lot of other cancers. In fact, I'm happy to report that anywhere in Jamaica where you do have, or colleagues have cancer, they can join any of our multidisciplinary tumor boards and present their case and get a consensus opinion on the best way of managing these patients. Because one of the things that we have clearly shown is that cancer-specific outcomes are better when the patients are discussed in a multidisciplinary tumor board, with improved clinical decision making, both for the patient and the clinical team, with lower permanent stoma rate, lower rates of recurrence. There's greater practice of evidence-based medicine with overall improved survival in patients with colorectal cancer. Another thing that we have added to the story of colorectal cancer treatment in Jamaica is laparoscopy. And laparoscopic surgery for colonic cancer, that is a patient who was a cecal or ascending colon cancer, or descending colon or sigmoid colon cancer, left hemicolectomy, sigmoid colectomy, or right hemicolectomy, or even total abdominal colectomy. In Cornwall, there's Dr. Harry, Milton Harry and team. In Central Jamaica, Dr. Lloyd and his team there. At KPH, we have Dr. Simpson, Dr. Smith, and team there. And at university, there are several others, Dr. Baker, Dr. Leek, and others who do practice laparoscopic surgery for colon cancer, with the benefits of minimally invasive surgery. Reduced length of stay, less pain, less potential for hernia formation, without compromising quality of cancer care. So no difference in cancer mortality. The operations do take longer. And in fact, it may require greater use of staples so that the initial expenditure is higher. But given the long-term benefits of less time in hospital, greater return to work, overall, the society benefits. And yes, cosmesis is also better with less pulmonary complications. So again, especially where beds are premium, you want to get the patient in, do the operation without or minimizing the physiologic insult to the patient, and therefore a quicker overall recovery, which is what laparoscopy does. And I'm happy to report that throughout the 3 counties in Jamaica, we can and are offering laparoscopic surgery for patients with colorectal cancer. Now, what about that 20 to 30% of patients who present with metastatic disease? The fact is, oftentimes these patients will go on to die from their disease. And whereas mainstay of therapy is in fact systemic therapy, some may require surgery. Those who are selected for surgery, and in fact here you will see that in the United States, up to 66% of patients are actually selected for surgery. So those who are selected for surgery actually do better. The fact is, most of the time, surgery is for obstruction. And we have to be a little bit more careful, because if the patient is operated on, overall their mortality tends to be a little bit higher than that 3 to 4%, and they are more likely to have perioperative complications. So we should always manage this, not just the patient, we also need to manage their relatives. But sometimes we can cure these patients. We can cure patients with metastatic liver disease and or metastatic lung disease. And in fact, sometimes we can do resection of the primary and the metastatic disease at the same time. Or we may resect the primary and later, after a period of systemic therapy, go for the metastatic disease. Or there are times when it may be wise to reset the metastatic disease first and the primary later. So these are all options that are given to our patients, and these are decisions that are usually made in the tumor board discussion. Now, I'll spend the next few minutes to talk about rectal cancer because whereas we lump colorectal cancer as a group, the fact is rectal cancer can be a different beast. It is an important part of the body. We often think or we act without much thinking when we have a patient who's diagnosed with colonic cancer, because most of the time you can remove the right colon, left colon without any significant obvious morbidity to the patient. But a patient with rectal cancer who may need loss of the rectum and anus is going to significantly affect the patient's quality of life. So rectal cancer refers to cancers that are within 15 centimeters of the anal verge. And even when the cancer is easily palpable, on digital rectal, you're feeling a mass at 6 or 7 or 8 centimeters from the anal verge. We need to do a full colonic evaluation to rule out synchronous lesions, which may be as common as 2 to 5%, but synchronous cancers, that is 2 to 5%, but synchronous adenomas may go up to 20, 25%. So a full colonoscopy is necessary. And if a full colonoscopy is not possible, then a CT colonography or a barium enema will be useful. Rectal cancer in the past was associated with high morbidity. These operations were done in low volume centers. Not many surgeons were experienced at doing surgery for rectal cancer. And oftentimes, in fact, up to 2010, about 60% of patients were being, in the United States, were being treated with some form of colostomy. But this has changed. No, not only do these patients get treated with colostomies, but sometimes, in fact, they will have higher morbidity, urinary dysfunction, sexual dysfunction, incontinence, and even when they have suffered through all of this, they're at higher risk of recurrence. And why is this? It was because initially the anatomy of the spread of the cancer locally was not fully understood, and the rectum was being removed, but not the total mesorectal layer was not being removed. And by not removing the total mesorectal layer, islands of tumor were left in nodes or in microscopic areas in the pelvis only to recur and cause the patient's death. So now, any surgery for rectal cancer should involve a total mesorectal excision. But before we embark on total mesorectal excision, we need to decide if these patients also should get preoperative radiotherapy. In fact, a patient who's diagnosed with rectal cancer should have a pelvic MRI, a rectal cancer protocol pelvic MRI, and this will help to determine the need for preoperative radiotherapy. So, the pelvic MRI will show if the tumor has gone through the rectal wall, that is a T3, patient should have a preoperative radiotherapy. Or if the pelvic MRI or endoscopic ultrasound showed an enlarged nodes, these patients should have pelvic radiotherapy before surgery. And usually radiotherapy is combined with some form of chemotherapy. So the pelvic MRI will show also if there is so-called extramural vascular invasion, and it predicts the likelihood of you to be able to do complete surgery. In other words, the pelvic MRI will say whether the tumor has gone through the wall into the mesorectum, in which case the patients should get radiotherapy. So neoadjuvant radiotherapy is recommended for all patients with clinical stage 2, that is a T3 or 3, clinical stage 2 and 3 rectal cancer. And this radiotherapy can be given by long course chemoradiotherapy or short course radiotherapy. Long course chemoradiotherapy is given over 5 weeks, and it's given in addition to radiotherapy, so-called radiosensitizing chemotherapy. In other words, a small dose of chemotherapy is given too. And the single most important role of either long or short course is that it reduces local recurrence. Good class 1 evidence that there's a reduction in local recurrence from greater than 20% to 9%, and at least one study has shown some survival advantage. Now, what if the patient's preoperative staging was not great and the post-operative resected specimen showed that the patient has T3 or 4 disease? These patients can get also post-operative, not can, but should get post-operative radiotherapy. The beauty about it is that preoperative radiotherapy is better because there's less radiation-related toxicity. It isn't that there's a survival advantage, but there's less radiation-related toxicity and reduced and better recurrence profile when the radiotherapy is given preoperatively. It is not to say that all patients must wait on radiotherapy. And in fact, that's an important point. Not all T3 need radiotherapy. There are so-called sub-innocent T3 where it's a well-differentiated tumor. And looking at the pelvic MRI, there is no nodal disease, and the circumferential margin is predicted to be not involved. These patients, in fact, can get, albeit that they have a T3 tumor, they can get upfront surgery and will do very well with that local recurrence rate of only 5% at 10 years. Now, which one should we give? Long course chemoradiotherapy or short course? The fact is, there's no difference in local recurrence. There's no difference in distant metastasis. There's no difference in overall survival. There's less acute toxicity with short course chemoradiotherapy, and there's no difference in high-grade late toxicity. The fact is the long course chemoradiotherapy is more effective at reducing pathologic downstaging. And so you can reduce a tumor, a big circumferential tumor, to be a small mass. In fact, it can reduce it to the point where there's complete clinical response. And when you embark on surgery, or should you wait 5 years, you realize, in fact, that there is complete pathologic response. There's no difference in sphincter preservation rate, whether you give long course or short course. So my opinion is that, albeit that we tend to practice long course chemoradiotherapy, the fact is we should have the short course as an option in Jamaica. And what it will do is that it will open up radiotherapy to more of our rectal cancer population who will benefit from this therapy. Now, I did mention, and I'll repeat, that anywhere between 10 to 20% of patients who are selected for neoadjuvant chemoradiotherapy, long course, will have complete clinical response, and should they go on to have surgery, no residual disease will be found. Or should they be placed into a watch and wait group, and you observe them for 5 years, anywhere between 10 to 20% will have no recurrence of cancer. So the fact is, radical surgery is not appropriate for all patients with rectal cancer. This is something that we have to say to patients. This is something that patients have to buy into. Because if they have had complete clinical response, then we have to embark on a somewhat of a labor-intensive and a patient-compliant process of watching these patients, reevaluating them at 3 to 4 month interval for the first year, and being careful with them, knowing that maybe up to 80% will get a recurrent disease. But fortunately, in about 20%, you'll have complete clearance of their disease. Now, my second to last slide really speaks to colorectal cancer and COVID-19, because certainly there's no doubt that there's reduced screening going on in the last, let's say, 12 months or so. There's reduced access to healthcare. you're having a symptom, but you decide to let's wait and allow COVID to blow off or reduce, or as the case, some GPs outright close the office. As a result, there's more emergency presentation of colorectal cancer in our population. There's delayed histopath reports. That's a big problem we are currently facing. As a result, there's delayed adjuvant therapy and overall poor outcome. So one of the things that we have to see happening and attempt to mitigate almost in our daily practice is the impact of COVID and on colorectal cancer and take measures to reduce this. So in conclusion then, colorectal cancer needs to be better managed in our population. I say if you think about colorectal cancer, investigate for it with a colonoscopy. We need to be doing more screening, and this includes education of general practitioners and the general population. We will get better outcome when the patients are managed in a multidisciplinary tumor board after multidisciplinary tumor board discussion and after appropriate staging, that is with CT of chest, abdomen, and pelvis and pelvic MRI for patient rectal cancer. And albeit that I have not addressed this, a lot of our patients the drugs need to be more affordable for our patients. With that, I'll stop. Thank you, and I'll make myself available for questions.
All right, thank you very much, Professor Plummer. Loaded presentation, lots of information. In fact, you have already generated some questions. I will just say to the folks who have questions, we will have a question and answer session at the end of the rest of the presentations. So with regards to time, we'll have to move on. So at this time, we will be asking Dr. Mills to come forward. He will be presenting on the basics of colon cancer screening. As I mentioned before, he was instrumental in the formation of the symposium on colon health. So he's a consultant gastroenterologist at UOWI and the president of the Association of Consultant Physicians of Jamaica. So at this time, we invite Dr. Mike Mills to come forward.
Good morning, everyone. Thank you to the Jamaica Cancer Society for allowing me to have this opportunity to present on colorectal cancer screening for this year. We know that the importance of screening has been talked about for a number of years now, but we want to take this opportunity to remind individuals that it is an important aspect to reducing the morbidity and mortality associated with colon cancer. So I'm just going to take this opportunity to share my screen. It is a timely reminder that the world of Marvel has interacted with the world of colon cancer in the last year. And we will be looking at the story that highlights this important medical condition. Now, everyone is familiar with the heroes that are displayed here, and they're always jumping out to save the innocent against various forms of evil. But sometimes even heroes need to be saved. And this is a story that we're going to be looking at today. Chadwick Boseman, I think everyone is familiar with this actor. He was diagnosed with colorectal cancer in 2016 at the age of 43 years old. And he died last year, August 2020. So, colorectal cancer screening, saving the next Chadwick Boseman. Here's young Chadwick Boseman. He attended Howard University in Washington, D.C., graduated in 2000 with a Bachelor of Fine Arts in Directing. In 2003, he had his first TV role. I'm pretty sure not many of us would have seen him at that time. In 2008, he appeared in his first feature film, again, maybe unbeknownst to most people. In 2013, most people would have recognized him in the picture 42, where he played the role of the baseball legend Jackie Robinson. In 2014, another seminal role where he played James Brown in the movie Get On Up. 2016, maybe not so much a highlight, but the movie Gods of Egypt came out and he was one of the featured actors in that role. However, in 2016 also was when he was first seen in the major way in Civil War, Captain America, and the role of Black Panther. And I think this is where most of us would have first come to recognize Chadwick Boseman. But also in 2016, when this movie came out, at some point he would have maybe had this look of reflection when he would have been noticing that he would have been having either constipation, abdominal pain, and quite likely passing blood in the stool. And this would have prompted him to visit his physician to get an idea as to what the symptoms would have been related to. Now, we are not privy to the details of his medical history because he kept them under wraps right up until the end. But we surmise that it may have gone something like this. He would have asked his doctor to run certain investigations to come to a conclusion. And one of the tests that he had would have been a colonoscopy. He would have asked questions about the colonoscopy. There would have been opportunities to review the various options available to make a diagnosis. Other actors would have been faced with similar dilemmas. Here's Will Smith having his colonoscopy, albeit for a different reason, for screening and not for symptomatic colorectal disease. Having famous people being associated with medical conditions is not new, but it does help to increase awareness of these conditions. Colonoscopy is one of these tools used in colorectal cancer screening, has a high sensitivity for cancers of the colon and also for precancerous lesions or polyps. It's a single session diagnostic tool and also allows some therapy to be done by removing polyps. The advantage is there's a long interval between these procedures, so 10 years if you have a normal colonoscopy. And that means that at the appropriate age, 1 to 2 examinations which are negative may be all that are required to reduce the prevalence, incidence, and morbidity associated with colorectal cancer. So Chadwick Boseman would have had his colonoscopy done. And even though this is not his colonoscopy, at some point within his colon, they would have detected a lesion similar to this. Colorectal cancer. And of course, 2016 is also the year that he would have been filming Black Panther for release. At this time, he would have already known his diagnosis of colorectal cancer. And yet still, he was able to perform admirably and memorably with this diagnosis. But he would have had some questions, of course. He would have asked his doctor, so how did the cancer just develop? Was it suddenly, overnight, or was it something that had been going on for some time? And his doctor probably would have said to him, well, colonoscopy at some stage would have been able to detect early signs or precancerous lesions called polyps. And here we have a normal colonoscopy showing a normal mucosa with no polyps at all. Perhaps if he had presented a few years earlier, there may have been the presence of a very small polyp. Or perhaps Even if he had presented a little later, the polyp may have been a little larger, but still amenable to resection at the time of colonoscopy. But we know that if you don't remove polyps early, they may develop to larger polyps with varying degrees of dysplasia, and ultimately may develop into colorectal cancer. Now, this is known as the adenoma carcinoma sequence and is thought to take approximately 10 years. And this is not a new theory. We know that the normal mucosa of the colon can go through a number of pathways to development of colorectal cancer. There's the adenoma to cancer pathway, which we described before, and there is an accelerated pathway, or the serrated polyp to cancer pathway. Now, there are a number of factors which will lead to the development of colorectal cancer. Listed here are a number of oncogenes and a number of tumor suppressor genes. And there are mutations within these genes which will predispose individuals to colorectal cancer. So, oncogenes are essentially the ones that promote cancer once there is a mutation. And tumor suppressor genes also promote cancer when there's a mutation, but in opposite directions. So think of the oncogene when it's switched on as being akin to the gas pedal in your car. It makes you go faster. It helps the cells divide rapidly and out of control, and so leads to cancer. And the tumor suppressor gene is almost like the brake of the car. But when you have a mutation in the tumor suppressor gene, then you may have the similar uncontrolled, rapid progression towards cancer. So he may have asked, so why didn't anyone tell him what tests to do before? He was 43 when he was diagnosed. He would not have qualified for screening. Or perhaps he may have, depending on his family history and his risk profile. If there's a risk of colorectal cancer in families, we advocate increasing the screening or accelerating the screening time from the typical age by up to 10 years before. But we don't know what his family history of colorectal cancer is. In 2016, the United States Preventive Task Force published their recommendations for colorectal cancer screening, looking at adults beginning screening at average risk at age 50 up to age 75, and stopping screening at age 75 for routine screening, and a decision made on an individualized basis to continue screening up to age 85. And these guidelines have been also suggested by other societies. So the umbrella organization, the US Multi-Society Task Force on Colorectal Cancer, made up of the AGA, ASGE, and the ACG, also published similar guidelines. Screening beginning at age 50 in average risk individuals. They suggested 45 in African Americans because of the increased morbidity and mortality associated with late presenting colorectal cancer. And they also recommended discontinuing screening when patients have reached age 75, and an individual decision made depending on the expected life expectancy of less than or greater than 10 years. In Europe, the recommendation is, again, mostly between 50 and 75, depending on the societies, for screening. And this is the same age group recommended by the WHO's International Agency for Research on Cancer. So perhaps he would have been too young for screening. But as you said, we don't know what his real risk is. Genetics play an important role. 70% of colorectal cancers are sporadic in nature. No known hereditary link. 10% have a definite inherited gene-related predisposition, and 20% have not so strong characteristics genetically, but there have been definite signals that there is a genetic component. And we'll go into these in more detail in another talk within this symposium. Risk factors for sporadic disease can be divided into modifiable and non-modifiable. So the modifiable ones would be processed meat, alcoholic beverages in excess of recommended consumption of 2 drinks in males and 1 for females, smoking, obesity, low fiber diet, and alterations in the gut microbiome, although these are not well determined. And then the major non-modifiable risk factor is, of course, increasing age. For high-risk individuals, we consider it to have a higher risk if there's a family history of a genetic disorder predisposing to colorectal cancer. Lynch syndrome, which occurs in 3%, or familial adenomatous polyposis in 1%. Inflammatory bowel disease is another higher risk condition, especially when there is involvement of the entire colon for duration of greater than 8 years. Previous history of adenomatous polyps, with a large polyps or high-grade polyps, or multiple polyps, and a previous personal history of colorectal cancer. So why age 50? Well, that was a recommendation which was being made because most cases of colorectal cancer occur in individuals who are about 68 years age, based on the National Cancer Institute's data. And similarly in Jamaica, the median age for presentation of colorectal cancer will be 65 years, according to data published in the West Indian Medical Journal. So looking at your adenoma carcinoma sequence of 10 years, then you'd expect to be picking up polyps around the age of 50 to begin, to make it cost effective for population screening. And if you look at the age distribution for colorectal cancer in Jamaica provided by the Cancer Registry, you will see the increased incidence in individuals over the age of 60. So it doesn't mean that there's no colorectal cancer prior to that, but to do screening at a population level before for these low numbers would not be cost effective. And similarly in the UK, the distribution follows the same pattern. Over the age of 60, you get a significant increase, justifying the cost associated with screening to match the benefit in reduction in mortality and morbidity. And most new cases will present at this age group as well. Again, pointing towards age 50 as being a reasonable starting time for screening at a population level. Now, the condition for screening includes not just knowing how the disease progresses or the pathophysiology of the disease, the natural history of the disease, which we do know, but also demonstrating that the disease has a very significant prevalence in the population. And colorectal cancer is no different. As described before, it's the 3rd most common cause of cancer-related death in Jamaica. And the incidence is anywhere from 12 to 16 per 100,000 for males and females, similar to other territories in the Caribbean, such as Trinidad, but much lower than those in the US, UK, Japan. In the US, the proportion of non-Hispanic blacks and non-Hispanic whites, you see here in red, non-Hispanic blacks have a very high proportion or rate incidence of colorectal cancer in males and females, and the mortality is highest in this group. So special interest must be paid there So at some point you would have said, well, how could we have prevented the development of colorectal cancer? And this is where screening comes in. So before symptoms present, you're doing one of these tests: fecal occult blood tests, colonoscopy, CT colonography, sigmoidoscopy, or fecal immunochemical testing are the tools which are advocated for colorectal cancer screening. Fecal occult blood test, FIT test, and FIT/DNA tests will be lumped together because they look at similar things. The presence of blood in the stool, thought to be there from an advanced polyp, so a large polyp, or polyp demonstrating high-grade dysplasia or early colorectal cancer. And just doing fecal occult blood testing has been demonstrated to reduce colorectal cancer deaths and presentations with advanced lesions in more than one study. And so it's advocated as being cost-effective in reducing this burden. FIT testing is a little bit newer. It's not available to us in Jamaica, but fecal immunochemical testing has an advantage over fecal occult blood testing in that it actually detects antibodies to the heme molecule. And so it's very specific for human blood, in particular lower GI tract bleeding. But this is compared to the fecal occult blood test, which we do routinely, where you have to distinguish between the peroxidase reaction of blood, yes, but also other things in your diet. Red meat, for example. Vitamin C can interfere also. And there are some vegetables, broccoli, for example, which can also interfere with the accuracy of the test. So individuals must be mindful to eliminate these before doing fecal occult blood tests to prevent false positives. If you combine DNA analysis with FIT testing, the specificity changes because you have a higher number of false positive results and therefore more colonoscopies being done. However, it's still an option available, although it's not recommended routinely. Until they've modified the kits to look at the DNA which is being tested, it is not recommended as a screening tool at the moment. So FIT testing on its own is a preferred screening tool in most societies. Canada in particular, I know. The US also. And the UK will roll it out on a national level. And it must be annual FIT testing if available. If you're using the traditional fecal occult blood testing, it must be biannually, twice a year. A stool sample is sent, and it must be done every year to be effective. CT colonography, another option for screening, available locally. Sensitivity of 82 to 92%, depending on the center, could be higher for adenomas greater than 1 centimeter. So if the polyps are of a fair size, it is likely that you will pick them up, but you, of course, will need to do an optical or regular colonoscopy afterwards to sample and remove these polyps if they're present. But this will be discussed in more detail again in the symposium. Flexible sigmoidoscopy. Of course, it's not going to cover the whole colon by doing a flexible sigmoidoscopy, but even just doing flexible sigmoidoscopy alone has been shown to reduce the incidence of individuals presenting with advanced lesions, and especially in combination with your fecal occult blood testing, has been shown to dramatically reduce the morbidity and mortality associated with colorectal cancer. Colonoscopy we mentioned at the top is your so-called gold standard test. Barium enema has no role. Capsule endoscopy is not yet recommended. And then there are some other serum markers for detection of various genetic components, but they are, again, not recommended for screening for colorectal cancer, not ready for prime time. So the objective is to diagnose patients very early. And we see that from national and international data, so from the US and from Jamaica. A lot of patients are presenting with distal disease or regional disease. Localized disease only makes up a third of our cases, so most patients are already quite advanced when they're presenting. The situation in the US is maybe a little different, but not far off. What's disturbing is that the 5-year survival is impacted heavily by the stage, and so the later patients present is the less likely it is that they will do well. For localized diseases, survival up to 90% in the US, but it falls dramatically to 14% for distant metastases at 5 years. Our own data supports a similar picture, with our survivals falling dramatically depending on the stage of presentation. And there's a lot of evidence that doing screening can change these numbers, however. So if you look at this graph, you'll see in 2016, GlobalCan presented this data, looking at the rates of colorectal cancer and the mortality associated with it in different populations. So this is the one pulled from the US, showing that there's a significant downtrend in the incidence of male and female colorectal cancer-related deaths from the mid-80s onward. And looking at this graph, looking at the incidence, similarly for the US, in red, you see a significant downtrend, whereas most other countries are either quite level or increasing still. And the difference here for the US, why they've achieved this downturn, and perhaps Japan, would have been the introduction of population-level colorectal cancer screening programs. Now, the uptake of these have increased significantly since 2000, where 19% of the population would have been screened, up to 55% in 2010. Among adults aged 50 to 75 would have had some type of colorectal cancer screening, and this is thought to account for the decrease in the incidence. Canada, the curves have kind of leveled off, so there may be an initial or there may be a trend looking now recently to see whether or not they also achieved the same thing, having rolled out national screening plans. And in the UK, again, similarly, there's a slight trend downwards, but not as dramatic as in the US. What's alarming, however, is that when you break out the data according to age, in the younger cohort, the incidence of colorectal cancer seems to be uptrending in the younger cohort, whereas it's decreasing in the older. And so this has really led to changes in the way we think about screening ages. Even though we're looking at 50, we should really be looking at maybe younger. And paying attention to various countries reporting on their incidence in the young, you're seeing that the numbers are not small. So there are a significant percentage tracking the increased incidence of colorectal cancer in younger and younger. So there is hope. But unfortunately not for everyone at this time. And as we know, individuals with colorectal cancer do have adverse outcomes. So organized screening programs are important. Locally, we do not have an organized screening program. We have opportunistic screening, where we do a risk assessment for patients who come in and discuss doing screening at the appropriate time. Suggestion is that you should send your patients for fecal occult blood testing twice a year, 3 samples of stool each time. And depending on what the results reveal, a colonoscopy or a colonoscopy, and if it's normal, every 10 years, or CT colonography every 5 years. And those are the options available to us locally. So who should be screened? So average risk individuals, the guidelines now are suggesting age 45 to 75. The data is emerging, and over the last 6 months, there have been recommendations looking at age 45, although they're not yet cemented into the guidelines, but more and more there are a thrust to start at age 45, and that is where the ACG in particular has started screening. So the American College of Gastroenterology does push 45 as a screening age. After age 75, there should be a discussion with the individuals as to whether they need to continue screening. But the aim is to improve outcomes, improving access to care, which plays a large role in improving mortality as we see patients who present early and have appropriate care, have the best outcome, even in resource-limited settings. And so you too, by taking on screening, can play a role in reducing this burden of disease from colorectal cancer. So please do your part in advocating for your patients for screening. Thank you.
Thank you, Dr. Mills. Boy, I can't help but, wonder at the graphics there. It seems as if you're going to be budding into the cinematographic area soon. Really look good there. Thank you very much. So we'll move on to our next presenter. Dr. Hagen is currently a senior associate consultant and assistant professor in the Department of Laboratory Medicine and Pathology at Mayo Clinic, Rochester, Minnesota. She received her medical degree from Creighton University in Omaha, Nebraska, followed by pathology residency at Dartmouth Hitchcock Medical Center in Lebanon, New Hampshire. She completed a gastrointestinal pathology fellowship at Massachusetts General Hospital in Boston. Following completion of her training, she practiced at the Medical College of Wisconsin in Milwaukee for approximately 5 years before accepting her current position at Mayo Clinic in 2019. Her areas of research interest include colon cancer, gastrointestinal graft versus host disease, and Barrett's esophagus. And this morning she will present for us hereditary colon cancer. What is the risk? Over to you, Dr. Hagen.
Good morning. My name is Katie Hagen. Thank you very much for the invitation to speak this morning. I'm a pathologist at Mayo Clinic, and today I'll be speaking about hereditary colon cancer. So we know the majority of colorectal cancers arise from conventional pathways and are sporadic in origin, but a subset of colorectal cancers are due to inherited mutations. Up to 10% of colon cancers are due to these familial pathways, with Lynch syndrome and familial adenomatous polyposis being the most well-known and common familial pathways. And today we'll focus on some of these more common familial pathways to colorectal cancer. So the objectives for my lecture today include understanding diagnostic features and associated cancer risks of common hereditary colon cancer syndromes, including Lynch syndrome and familial adenomatous polyposis. So we'll begin with Lynch syndrome, which is the most common hereditary colorectal cancer syndrome, accounting for up to 4% of all colorectal cancers. This is due to autosomal dominant mutations in DNA mismatch repair genes, with the most common genes being MLH1, MSH2, MSH6, PMS2, and EpCAM. These genes are responsible for post-replicative DNA proofreading, and so mutations in these genes lead to microsatellite instability. And the estimated penetrance for these mutations is up to 80%. These patients present with a few colonic adenomas and have a significant risk of colorectal cancer with an approximately 80% lifetime risk. This disease has also been called hereditary non-polyposis colorectal cancer syndrome, but this is a bit of a misnomer because we know these patients can have a few colonic adenomas. In addition to colorectal cancer, these patients also have a variable risk for other extracolonic cancers. In general, these patients present at a young age, with the average age of presentation being 45 years. The risk of various extracolonic and colonic adenocarcinomas depends on the mutation in which the patient carries. And so patients with MSH2 mutations have a fairly high risk of developing uterine cancer, colonic cancer, ovarian cancer, and gastric cancer. But they also have some risk of developing liver and bile duct cancer, urinary tract cancer, pancreatic cancer, cancers of the small bowel and brain. Similarly, patients with MLH1 mutations also have a fairly high risk of developing colonic, ovarian, uterine, and gastric cancer, and again have some risk of developing those other cancers. Patients with MSH6 mutations again have a pretty significant but slightly lower risk of developing colon cancer, uterine cancer, and gastric cancer. And similarly, patients with PMS2 mutations also have some risk of developing colon and uterine cancer. Mutor disease is a variant of Lynch syndrome in which the patients have one internal malignancy, most commonly colorectal cancer, and also skin neoplasms in the form of sebaceous adenomas or keratoacanthomas. And so here we see evidence of a sebaceous neoplasm on histology, and here we have a keratoacanthoma, which is this crater-like squamous proliferation. In the general population, sebaceous neoplasms are rare, especially below the neck, so seeing several sebaceous neoplasms in a patient could be a clue to this entity. The skin manifestations may also be the first manifestation of this disease, so it's important to keep this variant in mind to properly diagnose these patients. In terms of the colorectal cancers in these patients, oftentimes they have characteristic histologic features, which can include this peritumoral inflammatory infiltrate or peritumoral Crohn's-like inflammation. We can see evidence of mucinous adenocarcinomas. So here we see tumor cells floating in pools of mucin. And sometimes we can see a medullary carcinoma in which we have syncytial growth of tumor cells with prominent tumor infiltrating lymphocytes. In terms of screening colorectal cancers for Lynch syndrome, there have been various proposed criteria throughout the decades. The Amsterdam criteria were the first proposed criteria, and this was based primarily on family history, which, as you can imagine, was fairly hard to implement as family history is not always readily available. The Bethesda guidelines included criteria based on the patient's age, presence of various Lynch-like tumors, the various histologic features I showed you on the last slide, and family history. However, this was still estimated to miss up to 12% of patients with MMR gene mutations. The Jerusalem criteria suggested that we screen all patients less than 70 years of age with a new colorectal cancer, and this was still estimated to miss up to 15% of patients with MMR mutations. And then the selective criteria combined the Jerusalem and Bethesda guidelines, but this was still estimated to miss up to 5% of patients with mutations. And therefore, currently it's recommended that we perform universal screening for Lynch syndrome in all newly diagnosed colorectal cancers because this is the only method that approaches 100% sensitivity. Screening can be done either via mismatch repair protein immunohistochemistry or via microsatellite instability testing via a PCR test. Immunohistochemistry, when performed, is performed for the 4 major mismatch repair proteins, which again are MLH1, PMS2, MSH2, and MSH6. These 4 proteins form heterodimer complexes. So MLH1 pairs with PMS2 and MSH2 pairs with MSH6. And so when there's a mutation or an activation of one of these proteins, oftentimes you get loss of staining for the partner protein as well. So here we see an example of MSH2 immunohistochemistry. Again, this is a tumor that has a medullary phenotype, so kind of syncytial growth of tumor cells. And we can see that the tumor cells have lost staining in for MSH2, so this is an abnormal result. But we can see that the normal cells, so the lymphocytes in this case, retain staining and serve as a nice internal control, letting us know that the stain worked. The immunohistochemistry compared to the PCR does have several advantages. These include it being readily available, a quick turnaround time, and overall low cost. Additionally, based on the pattern we see on the immunohistochemical stains, this can help dictate which germline mutations to evaluate for. So, microsatellite instability can be due either to inherited mutations in Lynch syndrome, or it can also be sporadic in nature. And so once we have abnormal immunohistochemical results, our next step of action is to determine, is this related to germline mutations, or are these inactivations sporadic in nature? And again, the pattern of staining we see can help dictate our next steps of action. So loss of MLH1 and PMS2 staining is most likely to be sporadic in nature. So our next course of action would be to assess for BRAF mutations. If we find a BRAF mutation, this tumor is most likely sporadic in origin, and we can stop our workup at this point. If we don't find a BRAF mutation in our next set of analysis will include MLH1 promoter hypermethylation. And if we find this, again, this is most likely a sporadic case of colorectal cancer, and we can stop our workup. However, if we don't find MLH1 promoter hypermethylation, then the patient would be referred to genetic counseling and germline mutational analysis. If we see loss of staining for MSH2 and MSH6, or isolated loss of PMS2 or MSH6, this is most likely due to a germline mutation, and these patients would go straight to genetic counseling and germline mutational analysis. So a quick question to demonstrate these various patterns of staining. So you perform immunohistochemistry for mismatch repair proteins on a colorectal cancer, and you see that there's loss of staining for MLH1 and PMS2, which would be the next appropriate step. Would it be BRAF mutation analysis, germline mutational analysis, repeat the immunohistochemistry, or KRAS mutation analysis? And so the correct answer would be BRAF mutation analysis. So as I just explained on the last slide, loss of staining for MLH1 and PMS2 is most likely to be sporadic in origin. So our next step in the workup would be assessing for a BRAF mutation analysis. In contrast, in this case, we see intact staining for MLH1 and PMS2, but we see loss of staining for MSH6 and MSH2. And in this case, it's most likely due to an inherited mutation, and so this patient would directly be referred for germline testing. Oftentimes we get posed the question as to whether we can screen for Lynch syndrome and colonic adenomas, and this would obviously have the advantage of identifying patients that have not yet progressed to cancer. And if we look at patients that have known Lynch syndrome and we stain their adenomas, up to 70% of these patients will have abnormal staining via the MMR proteins. But with that being said, there's a high false negative rate. So up to 30 to 50% will be false negative, so show intact staining. And so this is not a sensitive method of detecting patients with Lynch syndrome. If we just look at the general population and young patients with adenomas and we screen them for Lynch syndrome, we find a very low percentage of these adenomas have abnormal staining for the MMR proteins. And so overall, staining adenomas is not an efficient or cost-effective way of identifying patients with Lynch syndrome. So only in very special circumstances should we perform immunohistochemistry on adenomas. Once we do identify patients with Lynch syndrome, they undergo pretty aggressive surveillance. It's recommended that they start undergoing colonoscopy every 1 to 2 years, starting around age 20 to 25. Because of the risk of upper GI tract carcinomas, it's recommended that upper endoscopy be performed every 3 to 5 years, starting at age 30 to 35. In female patients, it's recommended that they undergo endometrial cancer screening, and this can be done via yearly endometrial biopsy, transvaginal ultrasound, or measurement of CA-125 levels. And once the patients are past childbearing years, prophylactic hysterectomy can be performed. And additionally, in a subset of patients, especially those with MSH2 mutations, urothelial cancer screening can be performed via urinalysis starting around age 30. In addition to identifying patients with Lynch syndrome, screening colorectal cancers for microsatellite instability also provides important prognostic information. So in general, patients with macrosatellite unstable tumors have a better survival compared to those with microsatellite stable tumors. Additionally, this provides us with important treatment information. So again, patients with microsatellite unstable tumors are less likely to respond to fluorouracil-based chemotherapies, but on the other hand, they're more likely to respond to the newer anti-PD-1 therapies such as pembrolizumab. And briefly, I just want to mention the concept of Lynch-like syndrome. So this is a category in which you perform the immunohistochemistry for the MMR proteins, and it looks like there's an abnormal loss of staining, but you go on to do the follow-up testing and you find no BRAF mutation, no MLH1 hypermethylation, and no germline mutation. And so overall, this is a heterogeneous group of individuals, but it's been found that the majority of these cases are due to double somatic mutations in the tumor. And so these cancers are considered sporadic rather than hereditary. And unlike Lynch syndrome patients, these patients are not considered at increased risk for additional extracolonic carcinomas. And it's recommended that these patients undergo standard treatment and follow-up. However, their family members do have an increased risk of developing colorectal cancer, and it's estimated that first-degree relatives have approximately a 3% increased risk of developing colorectal cancers. So in these family members, it's recommended that they begin undergoing colonoscopy every 5 years, beginning around age 17 years or 10 years before the earliest family member was diagnosed. So switching gears now onto familial adenomatous polyposis. This is a more rare syndrome, and it is due to an autosomal dominant mutation in the APC gene, which is a tumor suppressor gene. This accounts for less than 1% of colorectal cancers, with an estimated incidence of 1 in 10,000. These patients develop hundreds to thousands of colonic adenomas, with essentially 100% risk of developing colon cancer if left untreated. At a histologic level, the very earliest lesion we see is these aberrant crypt foci, which consist of adenomas involving 1 to 2 glands. And as these lesions progress, they become macroscopically identifiable adenomas. Most patients will manifest with polyps in the second decade of life, and the mean age of cancer diagnosis is around 39 years of age. There's also an attenuated version in which the patients have a later onset of disease and fewer adenomas, generally less than 100, and they have a significant risk, but it's estimated to be only 70% risk of developing colon cancer. Again, the lifetime risk of colon cancer in these patients is essentially 100%, and therefore the majority of these patients will require a prophylactic colectomy. And here we see an example of a colectomy from an FAP patient where they have these numerous polyps studding the colonic mucosa. In addition to colorectal cancer, these patients also have an increased risk of developing duodenal or ampullary cancer, pancreatic cancer, thyroid, hepatoblastomas. A small subset will develop gastric cancer, and again, a small subset will develop brain cancer. Within the attenuated FAP, again, these patients have a high risk of developing colon cancer and also have some risk, again, of developing duodenal or ampullary cancer and thyroid cancer. Other extracolonic manifestations include the development of fundate gland polyps in the majority of patients, and up to 40% of these fundate gland polyps can have evidence of dysplasia, as we see here. Despite a significant number of these polyps developing dysplasia, very rarely do they progress on to gastric adenocarcinoma. The majority of patients will also have duodenal adenomas, and they can have congenital hypertrophy of retinal pigmented epithelium, epidermoid cysts, osteomas in the bone, supernumerary teeth, and adrenal adenomas. Up to 10% of FAP patients will also have desmoid tumors, with the majority of these being intra-abdominal in location. On a histologic level, these consist of a spindle cell proliferation with infiltrative borders. These tumors do not have any metastatic risk, but they can be locally aggressive and recur. And patients that have had a prior surgery are at increased risk for developing these desmoid tumors. There are various different treatment modalities that can be applied for these tumors, which include NSAIDs, estrogen receptor modulators, chemotherapy, radiation, or surgery. Diagnosis of this disease is made by identifying a mutation in the APC gene. APC gene testing should be considered in patients that have numerous adenomas over their lifetime, patients with a known familial diagnosis of FAP, patients that have a large number of adenomas in a single colonoscopy, those individuals with a family or personal history of early onset colorectal cancer, and individuals that have presence of extraintestinal features of FAP. Depending on where the mutation is within the APC gene determines the phenotype for the patient, and also if it correlates with development of the various different extraintestinal manifestations. Of note, it's important to know that 30% of cases are due to de novo mutations, and therefore these patients would not have an associated familial history. And finally, patients with the classic phenotype of FAP with but without an identified APC mutation can still have FAP. For instance, deep intronic mutations are very hard to identify. So if they classically look like FAP, you can't find the APC gene mutation, it's possible they still have this disease. Once these patients are identified as having FAP, they undergo surveillance. Annual colonoscopy is recommended starting at age 10 to 12, and in those individuals with the attenuated version, this can be started around age 20. As I mentioned, the majority of these patients will require colectomy. This can be done either at the time of diagnosis of colorectal cancer or if they have high-risk features, including advanced histologic features, large polyps, or an increasing polyp burden. Oftentimes, these patients will either undergo ileal pouch anal anastomosis or ileal rectal anastomosis, and this depends on the extent of rectal adenomas present. Those individuals that have ileal pouch anal anastomosis are recommended to undergo endoscopic surveillance of the pouch every 6 to 12 months, and those with ileorectal anastomosis, surveillance every 3 to 6 months. It's recommended that these individuals have a baseline upper endoscopy starting around age 20 to 30 years. Gastric polyps can generally be observed and biopsied. Duodenal adenomas are often biopsied, and depending on the number, size, and histologic findings, this dictates how frequently upper endoscopy should be repeated. Annual thyroid examination is recommended due to the increased risk of thyroid cancer, and some patients can undergo chemoprophylaxis with NSAIDs to help decrease the polyp count and polyp size. And briefly, I would like to mention MUTYH-associated polyposis, as this can clinically look like FAP. This is due to an autosomal recessive biallelic mutation of the MUTYH gene, which is a base excision repair gene. And so because this is an autosomal mutation, parents are not affected, but the individuals may have siblings that are affected by this disease. It is possible that patients with heterozygous mutations do have some increased risk of colorectal cancer, but they usually don't have the full spectrum of polyposis. And clinically, again, these patients look similar to individuals with attenuated FAP. They have several adenomas, but generally less than 100, with approximately an 80% lifetime risk of developing colon cancer. And it's estimated approximately 20% of patients that are suspected to have FAP and are not found to have an APC mutation may actually have this syndrome. In addition to colonic adenomas, these patients can also have serrated colonic polyps, and they also have a significant risk of duodenal adenomas and duodenal adenocarcinoma. So I'd like to finish with an unknown case. And so this is a case of a 10-year-old boy with a colonic mass who underwent resection. And here we see the large necrotic mass. And in the background, we see a few colonic polyps. At a histologic level, the colonic polyps represented tubular adenomas, and here we see the large mass represented an invasive carcinoma. Mismatch repair immunohistochemistry was performed on the tumor, and immunohistochemistry for MLH1, MSH2, and MSH6 showed intact staining in the tumor and the background normal mucosa, but PMS2 staining showed complete loss of staining in both the tumor and the background normal. So based on these findings, what is the most likely diagnosis? Is it constitutional mismatch repair syndrome, FAP, Lynch syndrome, or MUYTH polyposis syndrome? And so this is an example of constitutional mismatch repair syndrome. And this is a syndrome that is due to biallelic mutations in the mismatch repair genes. So in these individuals, both their parents carry a mutation for one of the mismatch repair genes, and the affected individual inherits one mutation from each parent. This is especially high risk in consanguineous marriages, and overall it's a pretty rare entity with an estimated incidence of 1 in 1 million. These individuals present with childhood and young adult cancers, and unfortunately very few patients survive into adulthood. The various manifestations include development of brain tumors from age 2 onward, with most of these being high-grade gliomas. Approximately 30% of patients will develop hematologic malignancies and leukemia from age 1 onward. About 40% will develop digestive tract cancers from ages 8 to 10. And these patients tend to have adenomas that rapidly progress into cancer. Additionally, these patients can have other Lynch syndrome-like tumors from age 20 onward, including endometrial cancer and urinary tract cancer. They can have café-au-lait spots, which are these pigmented skin lesions, and therefore can be mistaken for neurofibromatosis. And they can also have hepatic adenomas. A suspicion for diagnosis of this entity should be considered in children or young adults that have Lynch syndrome cancers, children or young adults with colonic adenomatous polyposis not explained by other known mutations, any child or young adult with cancers plus parental consanguinity, café-au-lait macules, or features of neurofibromatosis, and they're found not to have neurofibromatosis. Any cancer with abnormal immunohistochemistry for DNA mismatch repair proteins in normal or tumor tissue. And so in the example I showed you for the case, we saw complete loss of staining in both the normal and tumor tissue, where if you remember in patients with Lynch syndrome, they have loss of staining only in the tumor cells, but preserved staining within the normal tissue. Individuals with history of brain cancer, lymphoma, or leukemia without a history of radiation, and then any child or adult with a hypermutated tumor. These individuals are recommended to undergo annual colonoscopy beginning around age 6 to 8 and often will require a colectomy. They're recommended to have annual upper endoscopy and video capsule endoscopy beginning around age 8 to 10. Brain MRI every 6 months beginning around age 2. A CBC to assess for hematologic malignancies every 6 months beginning around 1 year of age. And endometrial cancer screening starting around age 20. And urinalysis starting around age 10 to 20. So we've covered some of the more common entities that lead to hereditary colorectal cancer, but obviously this is not inclusive of every single entity. And I just briefly want to mention that there are several other inherited syndromes that can lead to colorectal cancer, which we were not able to discuss today, which include hamartomatous polyposis syndromes, other adenomatous polyposes, and a serrated polyposis syndrome in which patients have serrated polyps of the colon as opposed to adenomas. So looking at the big picture of all currently known hereditary colorectal cancer syndromes and polyposis syndromes, we touched on a few of these entities today, but you can see again that there's several other entities out there that have been discovered. And then briefly, I just want to mention multi-gene testing. So most of the testing I discussed today was directed gene testing. But we now have the technology of next generation sequencing that allows us to sequence multiple genes simultaneously, and many institutions do offer panels for multiple genes. This multi-gene testing can be considered in patients that have criteria that meet criteria for more than one hereditary cancer syndrome, patients with colonic polyposis of uncertain histology, individuals with adenomatous polyposis. As you saw on the last couple of slides, there's several known mutations that can lead to that phenotype, in individuals where the family history is limited or unknown, and then as second-line testing if first-line testing is inconclusive. So to summarize what I've touched on today, proper diagnosis of patients with hereditary colon cancer syndromes allows patients and family members to undergo appropriate surveillance. Knowledge of the characteristic extraintestinal manifestations can help direct diagnosis of hereditary colon cancer syndromes. Knowledge of family history and mode of inheritance can guide our genetic testing that we perform. And then finally, universal screening of all colorectal cancers for microsatellite instability is recommended to identify patients with Lynch syndrome. These are my references, and I thank you for your attention.
Thank you very much, Dr. Hagen, for your presentation on hereditary colon cancer. And I'd also again like to thank Dr. Mills and Professor Plummer for their presentations as well. I'm also welcoming those who joined us since we started. Welcome. At this time, I can see we're almost at the halftime for the break. So I think we're gonna keep this as lean as we can. So what I'm gonna invite the panelists to do, Dr. Mills, Professor Plummer, and Dr. Hagen to do is just take a look at the Q&A, and you can choose for yourselves which one you want to answer, and we can try and wrap this up in less than 5 minutes. I'm not going to limit what you answer. So any one of you can choose. There's 3 of you, you can choose. Dr. Mills, it look like you want to go first.
I'm looking at the questions. I'm seeing one saying, as a Jamaican, can you explain to us why it is that Jamaican men always have a phobia when they have to do screening for colorectal and prostate cancer? Yes, it is true that historically we've had challenges getting men to practice health-seeking behavior, and screening is one of those. In particular, anything that involves a test through the rectum, which is what is involved for colorectal and prostate cancer screening. Education is one barrier, so individuals obviously would want to know exactly what is involved in the testing. That's one thing, but we can't get away from the fact that culturally we are still maybe not as comfortable discussing any examination of the rectum, and individuals really are placing an artificial barrier there, because the testing itself, both of them involve first a digital rectal exam, which some individuals may say that they are, not so in favor of anyone inserting anything into the rectum. And some of this is just, let's call it bar talk or veranda talk. But to get past this, it really involves getting individuals to recognize that the test doesn't do anything to you. It doesn't make you homosexual. And then, I mean, that's as blunt as you could put it, if that is the barrier that most men would describe openly. Outside of that, though, generally speaking, health-seeking behavior when an individual is completely well is traditionally lower in males compared to females. So we just have to try and get the word out, try and understand the potential barriers, have a one-on-one discussion with individuals, see what their particular fear may be. A lot of times when the individuals come to the office, they are amenable to have the test once explained to them, although they may be embarrassed about it. So this is just something that we just need to keep plugging at.
Thank you, Dr. Mills. Prof, I see there are 2 questions posted for you. You want to take one? Professor Plummer?
Actually, I can't see the question. If you read it, I'll just try my best to answer.
All right, you
it,
want me to
please.
read both or just one?
Yes, both. I think I just.
Okay. First one is, what are the preliminary signs of colorectal cancer? What is the survival rate if this cancer gets to stage 3 or 4? Next one say, neoadjuvant therapy is recommended for all patients and with clinical stage 2 and 3 rectal cancer. Yes, but can the patient be treated with bimount medication without neoadjuvant chemo or radiation and survive? If so, what would be the lifespan of such a patient?
All right, so let's take them in order.
We're going to answer to the one.
think. All right, so the first one I'd like to quickly say is we are here trying to promote screening as opposed to allowing someone to have symptomatic disease, that is bleeding or belly pain, changing their bowel habits. That's how colon cancer might present. But bear in mind that up to 30% of patients, by the time they notice those symptoms, they have metastatic disease, and cure rate is going to be low. And I think Dr. Mills said it, 14% at 5 years, but we don't have many people surviving beyond 5 years when they present with metastatic disease. So let's not wait for symptoms. Let's use the age limit of 45 to 50 and have a colonoscopy or fecal occult blood testing or FIT or flexible sigmoidoscopy or CT colonography as a standard. And just to say, if a patient presents with stage 2 or 3 disease and needs neoadjuvant therapy, that's what's going to give the patient the best chance of outcome. Chemotherapy there's some chemotherapy that can be given as oral, Zeloda, and we'll hear more about that later. But a lot of times it's the intravenous and combined with oral. And yes, if it's rectal cancer, radiation also has a role. So I think patients and doctors and individuals should try and best to listen to their doctors, use the conventional or standard therapy. And this is what the science and the evidence proves gives the best outcome, which is really what we are promoting.
All right, thank you, Dr. Plummer. I've only seen one question here, which would probably be for Dr. Hagen. Are you able to see it? It says, I have a sister, niece, and a cousin who passed away from colorectal cancer. One in Canada, one in England, one in Jamaica. Is this type of cancer and hereditary cancer?
This would certainly be a strong family history of colon cancer. I would recommend that you talk to your PCP, and they can take a full history and potentially do any follow-up testing, potentially recommend you to a genetic counselor, and get you started in a screening program at the appropriate age would be my recommendation. But hard to say for certain this is hereditary or not, just based on that information.
All right, thank you. I see another one here from a Marlon Reed. Are you able to see? Oh, Professor Plummer can't see it, so I'll have to read it. What is the family history for the 31-year-old female, and was genetic testing offered? If not, what are the challenges in obtaining genetic testing? And the final comment is, how about a collaboration with Dr. Hagen?
All right. The family, the particular example I gave, the patient lacked any positive family history of any cancer. And 70 to 80% of the case, that will be the case, where out of the blue, a cancer seems to occur in this young patient. We do have genetic testing in Jamaica. It's fair to say that just using saliva or buccal swab somewhere in Kingston, and if you can contact me directly, or any of the gastroenterologists, surgeons, radiologists, anyone involved in cancer care, know of the institution where genetic testing for most of the known abnormalities to determine the risk and also to plan treatment that's currently available in Jamaica.
All right, this is the last one. Not quite sure who is going to take it. It's from Nichole Spence. It says, what are the implications of testing early for colorectal cancer, even if you do not have a family history? Early testing being under the age of 45, say 30 or even younger.
Okay,
Were you typing a response, Dr. Mills?
I started to answer in the chat, but no problem. So in essence, there are two approaches to the screening. There's the individual recommendation for screening, and then there's the more national level for screening. Certainly the screening that takes place at age 45 or 50 at a national level makes sense because based on the incidence of colorectal cancer and the age with which it presents, you're more likely to pick up a significant number of early cases by doing it at this age, 45 to 50. If you were to drop the age to 30, for example, across the board for population, and not being able to show that a lot of people have colon cancer at that age, then you will basically be wasting resources because the vast majority of your tests will be normal or negative, and you'll be increasing the spend on these diagnostic tools without having a lot of yield, basically. So at a national level, it wouldn't be useful. For an individual, so if one individual said they wanted to do testing at age 30, yes, it's true that potentially you might just happen to find a polyp in that person, but whether you have changed their outcome long-term or not is debatable. So again, on average, we would not suggest doing screening at that age across the board. Usually if someone is presenting at age 30 and asking for a colonoscopy, they may have some symptoms which they want to get checked out, and that's not a problem if there are symptoms which warrant a colonoscopy, definitely. But by doing it across the board at age 30, you'd be displacing resources and taking away from the goal, which is to reduce cancer at a wider level. So that's the reason why we don't do it at a younger age, unless there's a risk factor, a higher risk individual. So for average risk, we would not be recommending that at this stage, no.
All right, thank you, Dr. Mills. I do not see any more questions, neither raised hands. I noticed in the chat that people appreciated the presentations. And I think most of us, I would assume, are satisfied. I would also personally like to thank all who have participated, starting with Mr. Jarrett, Professor Plummer, Dr. Mills, and Dr. Hagen. And I would like to say to you all and to all our attendees, thank you all for having me as your moderator. So I think at this time we will take the break, and after the break, Dr. Longmore will be your moderator.
Do we know what we're eating? Important information about unhealthy foods doesn't always get to us, and this can lead to wrong choices.
1 in 2 Jamaicans is either overweight or obese. Obesity increases the risk of heart disease, type 2 diabetes, and 13 types of cancer.
We have the right to know what we're eating. Especially now, we need clear food labels. What's in our food? Give us the facts. A message from the Heart Foundation of Jamaica, Ministry of Health and Wellness, and the National Consumers League of Jamaica.
With over 20 years in providing quality service, Apex Radiology is Jamaica's premier diagnostic facility. Our services include CT scans, nuclear medicine, ultrasounds, x-rays, and more. We have 3 easily accessible locations in the Kingston area and 1 in Ocho-Rios. With our mission to provide exceptional and affordable healthcare, Apex Radiology is a clear choice for your diagnostic needs.
Good morning, everyone. Following on some excellent presentations from this morning, we're going to try to launch right into the second session of this symposium. I'm Dr. Chapman Longmore, general surgeon at the Connor Regional Hospital. And greetings from the West, for both locally, for those locally and abroad. We're having some great weather here in Montego Bay. And hopefully soon we can resume face-to-face meeting so we can share this weather with you guys. Until then, this is where we are. Without further ado, we're going to kick off this second session with a presentation from Dr. Nichole Grant. Dr. Grant is a consultant radiologist, works from one of the more prominent diagnostic centers in the island and certainly in the West, Radiology West. Dr. Grant obtained her BSc in biochemistry and zoology from the University of the West Indies, as well as her MBBS and DM in radiology. She had a fellowship done in virtual colonoscopy training out of the University of California, San Francisco. And without further ado, Dr. Grant, we're going to invite you to take the podium at this point and launch into your presentation.
Hello, everyone. I'm Dr. Nichole Grant. I'm going to be taking you on the exciting journey of imaging in colon cancer. Thank you to the Jamaica Cancer Society for having me. And let's get started. I'm going to share my screen now. The path that we will take will include introduction, a few tidbits that I think will be good for you to know as the basis of, as the presentation as we go through, diagnosis, staging, evaluation of treatment response and follow-up, minimally invasive interventions, and what's new. As you've probably already heard today, colon cancer is the third most common cancer in Jamaican men, second most common cancer in Jamaican women, and most importantly, it's the most preventable form of gastrointestinal cancer. We often use colon cancer and colorectal cancer interchangeably. However, there are important differences between colon and rectal cancers. Rectal cancer is less common and potentially more dangerous. The rectum doesn't have a serosa, so it's easier for the tumor to break through and spread locally. And rectal cancer has a 20% risk of local recurrence versus a 2% risk with colon cancer. So it's 10 times more likely to have local recurrence with rectal cancer. Anatomy, lymphatic and vascular drainage, and therapeutic options of colon cancer differ significantly from the ones of rectal cancer. In rectal cancer, an exact local regional staging is essential, whereas in colon cancer, other challenges like ruling out a second cancer, proximal to a stenosing tumor, plays a more important role. Now, I hope a lot of you, maybe some of you, will remember these famous detectives and private investigators. I hope you're as long in the tooth as I am. But imaging are just like these very detectives. We give you certain information. We give you the who, we give you the where, and we give you the what. Multiple modalities encompass the whole spectrum of imaging techniques that play the important roles. So diagnosis is the who, staging is the where, and the evaluation of the treatment response is the what, followed by follow-up and the minimally invasive interventions. Now the who. We want to know who we're dealing with. Is it a rectal cancer? Is it in the colon? If it is in the colon, is it in ascending colon, transverse colon, or descending colon? This picture highlights UK incidences of the locations of their cancers. And as you can see, the rectum has the highest percentage in both their male and female populations. In a 2017 study done locally that had looked at our cancer registry between 2011 and 2014, I believe it's Plummer et al., it also demonstrated a higher incidence of our cancers in the rectum. I think it was in the 27% thereabout. But did you know that approximately 35% of patients with colon cancer have an associated synchronous adenomatous polyp? Approximately 5% of patients with colon cancer have more than one cancer at diagnosis, sadly. Mucinous and signet cell tumors are subtypes of colorectal adenocarcinoma. They're associated with a younger age, advanced tumor stage, different tumor spread patterns, and poor response to neoadjuvant chemotherapy and radiation therapy. On CT, features of the mucinous adenocarcinoma include presence of intratumoral calcification, common heterogeneous contrast enhancement. It may show severe, more eccentric bowel wall thickening. It can produce cystic or calcified hepatic metastases, as well as widespread intraperitoneal metastases. The modalities that we use for diagnosing our colon cancers and colorectal cancers include CT colonography, CT abdomen pelvis, MRI pelvis, and barium enema. CT colonography is a fairly recent modality, commonly used. However, it is indicated in cases of failed conventional colonoscopy due to non-passable stenosis or obstructing cancer. It is important in tumor localization for laparoscopic surgery, as in it can give you an accurate segmental tumor location. In patients that are elderly and frail, patients that have bleeding diatheses, and patients that have sedation issues. It has evolved to become an alternative to optical colonoscopy for the detection of colorectal neoplasias. It is highly accurate in assessing synchronous cancers and advanced neoplasia. The technique involves cleansing the colon with oral laxatives, insufflation of air or CO2 through a rectal tube, and CT images are subsequently obtained at sub-millimeter resolution. A volume model of the colon is constructed from the spiral CT images. And here we have a video demonstrating what the 3D images look like. Currently not playing. Let's see if the other one will. We will return to that. These, however, are the source images. This is a coronal oblique view, as you can see here, demonstrating an obstructing transverse colon tumor. And you may say to yourself, "Oh, what's the big deal?" That can be diagnosed on any CT or on colonoscopy. But what is important to note is that there is a large polyp in the cecum/ascending colon. Under conventional colonoscopy, the scope may not have been able to traverse this stenosing tumor to make the journey to find the diagnosis of the more proximal polyp. CT abdomen pelvis, its primary role is in staging. However, often diagnoses can be made in patients that present with acute symptoms, such as complications of their tumor, perforation, etc., or as an incidental finding for another pathology that they present for. Here I have an image of a 60-year-old gentleman that presented with abdominal pain. And as you can see here, there is a thickening heterogeneity of the distal transverse colon with a pocket of air adjacent to the colon, as well as extensive mesenteric stranding. This gentleman had perforation secondary to his tumor. It's also important to note that he has a family history of colon C, and so screening would have been very useful in his case, as he sadly went on to have a total colectomy. MRI, its role is in staging of rectal tumors and assessment of liver metastases. Extension of the tumor into the mesorectal fat and the potential invasion of the mesorectal fascia can be delineated. Infiltration of the mesorectal fascia or distance of the tumor to the mesorectal fascia less than 1 millimeter is associated with a higher risk of local recurrence. The distance of the distal part of the tumor from the anorectal junction is quite important, as well as assessing the sphincter infiltration, as well as extramural venous invasion. Mucinous and non-mucinous rectal tumors can be differentiated with MRI imaging as well. And mucinous tumors tend to be more heterogeneous with intermediate and high signal intensity on CT-weighted fast-spin echo images reflecting the mucin content. And this is an axial image of a patient that is suspected to have a mucinous tumor. As you can see here, this is a large fungating rectal mass causing stenosis of the rectum. This is another axial T2 view, as well as a sagittal view to give you a nice picture of what the tumor looks like. This is another patient with an anorectal tumor, as you can see, extending here through the fascia. This is the sagittal view of that same patient, distal rectal tumor and anal tumor right here. Barium enema has been used extensively in the past for imaging for colon cancer. This is, however, now thought as a third-line method if colonoscopy and CT colonoscopy are not available. First world countries really have eliminated the use of barium enema. However, in our setting, there have been, given economics and so on, there have been cases where we can still use barium enema and it can give us information. This was a 70-year-old gentleman, symptomatic, pure bleeding, I believe he presented with an abdominal pain, weight loss, so on. And he did his barium enema. And as you can see here, this is such a typical med school apple core deformity of the distal sigmoid colon, in keeping with a tumor. He went on to have a CT that demonstrated the large sigmoid colon mass here on axial images, as well as here on the sagittal images. Rectal contrast was administered to give us better delineation. Now, staging, beware. What modalities do we use? For both rectal and colon cancer, ruling out metastatic disease prior to potential curative surgical approach is mandatory. And of course, you all are familiar with the TNM staging: tumor, nodal metastases, distant metastases. And this is just a quick picture to demonstrate the tumor location for the different stages. So as you can see, stage 1, the tumor is still within the wall of the colon, abutting the serosa stage, and that's stage 1 and 2, sorry. Stage 3, extending through the serosa. Stage 4, extending through the serosa. The relationship of tumor to surgical planes, example, the circumferential resection margin and anal sphincter involvement, is important in staging. The depth of the tumor spread, extramural vascular invasion, the presence of malignant lymph nodes, and presence of tumor deposits are important things that we need to relate to our surgeons with our imaging modalities. Metastases or metastatic disease, commonly liver, lung, and peritoneal cavity for colon cancer. Liver metastases being the most common one. 60% of patients who develop metastases present with liver mets, and it's already present in diagnosis in 15 to 20% of cases, sadly. The American College of Radiology appropriateness criteria are guidelines, evidence-based guidelines that we use for specific conditions, which allow us to delineate which modalities are best for staging. The ACR guidelines, I think it's a little bit cut off here, but the ACR guidelines grade the different modalities as in, 1, 2, and 3 usually not appropriate, 4, 5, and 6 may be appropriate, 7, 8, and 9 usually appropriate. And as you can see, CT chest, abdomen, pelvis with IV contrast is the highest graded modality for pre-treatment staging of colorectal cancer when evaluating for distant metastases. I'm often asked, and as I'm sure a lot of you get the same question, are chest X-ray and abdominal pelvic ultrasound adequate investigations if there are financial challenges, as a lot of our patients encounter? The sad answer is no. Although we want to do and help as best, it is not adequate. Chest X-ray is no longer recommended as a part of staging. A 2015 study demonstrated that chest X-ray does not improve the detection of occult malignancies. Ultrasound as well is user dependent on the quality of equipment, and detection of small lesions is very difficult. So our modalities used are CT chest, abdomen, and pelvis with IV contrast, and MRI abdomen, pelvis without and with IV contrast, along with CT chest. CT chest, abdomen, pelvis is performed as a multi-phase contrast enhanced study. And this is just an image of a patient that presented with a rectal cancer. You can see it here, thickened heterogeneous rectum. This patient had nodules in the mesorectal fat. Patient also had multiple hepatic lesions, heterogeneous lesions that you can see here, as well as 2 right lower lobe pulmonary nodules. I just showed you the largest one. Evaluation of response, which is the WAPS. And hopefully, we all hope that once our patients start their chemoradiation, this will be the colorectal cancer curing and going away and responding well. The evaluation of treatment response is an assessment of the post-treatment tumor response, tumor regression, for example, tumor regression grading in MRI imaging, response to systemic and liver-directed therapies, to detect drug toxicities, and surveillance after therapy, i.e. to detect disease recurrences. Hopefully there are none. All imaging methods used for staging are principally also applicable to patient follow-up. MDCT is the most commonly used modality. And patients do approximately 3 to 4 scans in the first year of their diagnoses. There are different criteria that we use when we're evaluating the treatment response. RESIST criteria 1.1 is a response evaluation criteria in solid tumors. And this is a set of published rules that's used to evaluate or assess tumor burden in order to provide an objective assessment of response to therapy. The RESIST 1.0 was the first criteria, and it was upgraded. So the new criteria, 5 targets, 2 per organ. So it's 5 lesions. So if it's the 5 largest lesions in the liver, 5 largest lesions in the lung. For lymph nodes, you measured the short axis diameter. The progression of disease, if it's a 20% increase, and so on. This did not project well. My apologies. This is the MRI tumor regression grade, and it goes from grade 1 to 5, and basically applicable in rectal tumors. And it's assessing, if there's complete radiologic response, there's no evidence of tumor, have good response where there's dense fibrosis but no obvious tumor, and to no response where the images and the tumor remain unchanged. Minimally invasive procedures include CT-guided radiofrequency ablation and microwave ablation. Not all of these procedures are available locally, but we live in prior to COVID, we can travel, patients can travel abroad for treatments. Transarterial chemoembolization is also another minimally invasive procedure that is used to locally treat tumors and their metastases. This segment is a little bit of what's new and what's not so new. Dual energy spectral CT, 2 energy types basically differentiating tumor to better delineate tumor tissue from regular tissue. MRI colonography, similar to CT colonography without the radiation. However, it's a longer procedure and less affordable. Ultrasound elastography, not so new. I'm sure a lot of you are familiar with it. Useful in evaluating, rectal tumors via transrectal ultrasound, as tumors tend to have stiffer tissues when compared to regular soft tissues. MRI imaging-based magnetizing transfer, also a new modality to best delineate tumor tissue versus soft tissue. Advanced liver imaging techniques, functional and molecular imaging. Those are, the newer things. So in summary, the things that I want you to take away from the presentation is that colorectal cancer is preventable. So please screen, advise your patients to screen, family members, loved ones. The imaging modalities for colon cancer diagnosis, CT colonoscopy, CT abdomen pelvis. The imaging modalities for staging colon cancer, CT, chest, abdomen, pelvis. Imaging modality for staging of rectal cancer, ideally MRI, abdomen, pelvis, along with the CT, chest, and your follow-up images, follow-up of your patient's CT, chest, abdomen, pelvis. Thank you for having me. I hope you had a good time, and I hope you learned something.
Thank you, Dr. Grant, for highlighting and updating us on the pivotal role that our radiology colleagues play in the management of colon cancer. Certainly, a lot of us have learned something as well. Our next presenter is Dr. Jodie Taylor, Dr. Jodie Taylor is a consultant hematologist oncologist who is currently employed at the oncology department at the Cornwall Regional Hospital. Dr. Taylor will be presenting to us at this point on chemotherapy, what to say to patients. So Dr. Taylor, I'm going to invite you to come in and offer your presentation at this point. Thank you.
Good morning, everyone. Thank you to the organizers of this colorectal cancer symposium for having me. I am Dr. Taylor, and I will be speaking on medical management of colorectal cancer, more so what to say to patients. At this time, I will be sharing my screen. Just give me a minute. Colon cancer management, what exactly to say to patients. I've actually adjusted the topic to include not just chemotherapy, but also the current medications, specifically targeted therapy that we do have available to treat our colon cancer patients. So as was previously mentioned in Dr. Plummer's presentation, about a quarter of the patients who present to us with colon cancer have stage 4 disease at presentation. He quoted figures of up to 30% of patients. In patients who present with early stage disease, about 50% of them will convert to developing metastases. So it's very important in terms of the treatment that we offer and in patients presenting early, which goes back to the screening, which is being recommended for patients who are at the age where screening is recommended. The 5-year survival rate is obviously very much less for patients who have stage 4 disease, 5% to 10% quoted in some literatures, and for early stage disease, it's up to 74%. So the earlier you present, the better. So at the time of presentation, a number of our patients will have questions or concerns, and they'll voice that with their oncologist. And this includes what is chemotherapy? Do I have to take chemotherapy? They've heard many things about chemotherapy, usually nothing good. So they'll say chemotherapy kills good and bad cells, chemotherapy kills. And inheriting those concerns, there is some truth, but it is not totally truthful. Chemotherapy will help more than it hurts. Why do I need chemotherapy? They've heard from strangers information on chemotherapy or treatment for cancer, and their concern will include the side effects. Will I lose my hair? Thankfully, for our patients who have colon cancer, a lot of the first line treatment in terms of chemotherapy that we offer does not cause hair loss. So that's always a positive during the first consultation. They'll ask you what other treatments are available. A lot of patients are interested in herbal treatments, which sometimes, we are not able to give them much information on that. But big on the list will be, can I be cured? So we will also be interested in investigation. So all the patients, as previously mentioned, they do need to have a staging CT, chest, abdomen, and pelvis. We will ask for some blood investigations, including the carcino embryonic antigen, which is a tumor marker for colon cancer. They would have come to us with whether a biopsy report or some pathological report if they've had resection of their colon cancer. And patients are usually advised to have colonoscopy at their first interaction with the surgeon or gastroenterologist. But some people do present with surgical emergencies such as obstruction and may not have come to us with a colonoscopy report. In certain subgroups, we will ask for an abdominal or pelvic MRI, and in some cases, PET-CT may be indicated. All patients, as previously mentioned by some of the presenters, should have their tumor tested for deficiencies in the mismatch repair proteins or for microsatellite instability. And this informs treatment for patients who have stage 2 disease. It is a screening test for patients who potentially have Lynch syndrome, and certainly for patients with stage 4 colon cancer. It does inform the therapeutic options that are available, specifically immunotherapy, which is recommended in patients who have MSI high tumors. So we do make this recommendation for patients because of cost or sometimes availability. This may not be done, but for all the clinicians or physicians who are taking part in this symposium, this can be facilitated through most pathology offices in terms of the sample being sent abroad. Certainly, we do facilitate this through our pathology department at Cornwall Regional Hospital. Other investigations or testing that should be done on the tumor tissue, more so for patients who are stage 4, would include RAS mutation testing. So we test for different mutations in the cancer specimen. So that would include RAS testing and BRAF testing, and for some cases, whether there is overexpression of HER2. And this is important for patients who are stage 4 because certain of the treatments that we offer for that stage, we would have to know what if these mutations are present. What is also important to say to the patient by the oncologist is that we do rely a lot on what exactly is in the pathology report for patients with stage 2 colon cancer. Current recommendations for stage 2 colon cancer includes observation or chemotherapy. Chemotherapy can be considered. There are certain high-risk features in the pathology report that we will look for that will push us more in the direction of recommending adjuvant therapy for the patient. So if there's perineural invasion, invasion in the blood supply, lymphatic drainage involvement, lymph node, the number of lymph nodes that are evaluated, certainly current recommendation is that at least 12 of the lymph nodes need to be examined by the pathologist. How closely the tumor resembles native colon cells, how differentiated it is, whether there was any perforation, the surgical margins, etc. So that is important for your oncologist review, especially for stage 2 colon cancer patients. So I want it to be understood that colon cancer treatment is not limited to chemotherapy. The treatment for, I think, all cancers has been evolving. It continues to evolve, and colorectal cancer treatment is no different. So not all stages of colon cancer will require treatment. So many patients will be happy to hear that, particularly if you are a stage 1 patient and for some of the stage 2 patients. And the treatments that we recommend, they're based on research, and these treatments would have shown that they work and that they improve how long a person will survive or be cured from colon cancer. As I said before, chemotherapy is not the only treatment for colon cancer. You can combine chemotherapy with targeted therapy, and chemotherapy, patients will ask, what is chemotherapy? Simply using cytotoxic drugs to kill cancer cells. So these drugs usually are not necessarily very specific when you compare them to targeted therapy, but they work in terms of causing some of them DNA damage and affecting how the cell grows or divide and stopping cell growth. It's more the question about whether chemotherapy will affect good and bad cells. It is true that some good cells can be affected by chemotherapy, but more so cancer cells are the ones that will be affected by chemotherapy because they are usually rapidly growing cells. Targeted therapy uses drugs that will, target genes, specific genes in the cancer cell, and certainly certain proteins that are involved or important for cancer cell growth and also their survival. So your oncologist will say to you that in terms of deciding whether or not you need systemic therapy, that we take into consideration the stage of the colon cancer, as I mentioned before, the microsatellite instability status of the tumor, high-risk features in the pathology report for patients who are stage 2, and other factors such as performance status, how strong the patient is, that will decide whether we offer treatment or not. So for stage 1, colon cancer surgery remains the standard of care. So if you fall into this category, many patients will be very happy. For stage 2, colon cancer, some patients will, can be observed. Certainly, this is because adjuvant chemotherapy improves survival by about 2, maybe up to 5%. And studies have been conflicting as to whether, how much improvement, adding chemotherapy to giving chemotherapy to patients who are at this stage, whether or not it's helpful. So patients who have high-risk factors, though, that I previously mentioned, will certainly recommend chemotherapy for those patients, and the chemotherapy can be whether single agent, 5-FU, or capecitabine. So it's mainly fluoropyrimidine-based chemotherapy. Microsatellite instability, again, this is very extremely important for patients who are stage 2. Once there is lack of or deficiency in the mismatch repair proteins, or if there is there's found to be that the tumor is microsatellite instability high, these patients, when they are stage 2, do not do well with 5-FU or fluoropyrimidine-based chemotherapy. Their survival can actually be negatively affected. Certainly, chemotherapy for these patients can actually be detrimental to them. So this goes back to the recommendation that all patients with colon cancer should have microsatellite instability testing done, and particularly for stage 2 patients, it's very important for the oncologist to know this, to decide on what treatment, if any, we will give to these patients. So for stage 2 colorectal cancer, options for treatment that will be discussed with the patient would include observation, as I mentioned before, and certain chemotherapy options. We can either do single agent chemotherapy, capecitabine is a tablet, or 5-FU is an intravenous version. Certainly, capecitabine is just 5-FU in tablet form. It's a prodrug of 5-fluorouracil, but obviously a tablet may be more convenient for some patients, even though I have come across patients who prefer to receive intravenous therapy as opposed to having to take tablets. If we add another chemotherapy drug, which is intravenous oxaliplatin, to whether the capecitabine tablets or the 5-FU intravenous chemotherapy, then we come up with the acronyms CAPOX and FOLFOX. Those regimens are also an option, even though it must be noted that the addition of oxaliplatin may not necessarily offer a survival benefit for the patient. Certainly, if a patient has high-risk features, though, one may decide to give them a combination therapy with the Capox or the FOLFOX. For patients who have stage 3 colorectal cancer, adjuvant therapy or systemic therapy does help in terms of offering a survival benefit for the patient. Certainly difference 5-year disease-free survival in one meta-analysis that looked at stage 3 colorectal cancer patients found a difference of about 14 to 15%. And so all our stage 3 colon cancer patients should be offered adjuvant therapy. And for this stage, the main adjuvant treatment that we currently have is chemotherapy. In the latest NCCN guidelines, patients are stratified according to their risk of recurrence. And so you have some that are low risk and some that are high risk. Your risk in terms of discussions with the patient would depend on what we find in the pathological pathology report, looking at the extent of the tumor, the T-stage, the local extent, and whether there is nodal involvement, how many lymph nodes are involved. So for your patients who have like stage 3C, colon cancer, definitely we would opt more to offer 6 months of like FOLFOX therapy, right? For patients who are low risk, the option is therefore either Capox or FOLFOX. Certainly any stage in terms of stage 3, you can offer either. The difference though is that currently with respect to capecitabine, which is a tablet, and oxaliplatin, the intravenous medication, research has shown that 3 months or 6 months of this treatment, neither the 3 months is not inferior to 6 months, and that is important because patients who have been exposed to oxaliplatin do know of the long-term effects in terms of neuropathy, the numbness that they will experience. Some patients, depending on the extent of the neuropathy, nerve damage to their hands, their feet, they will have difficulty writing, buttoning their clothes. So long-term post-treatment, these are things for the oncologist to consider in terms of exposure to chemotherapeutic drugs. So for right now, patients can be given 3 months of Capox and 6 months, so oncologists can feel comfortable doing that. And if you are going to offer FOLFOX, though, the current recommendation is that they receive 6 months. And all this information was based on this trial. They studied the International Duration Evaluation of Adjuvant Therapy Trial, the IDEA trial, which showed that patients who received Capox, 3 months of Capox, their survival, their 3-year disease-free survival was similar to patients who received 6 months. For patients, though, who received the FOLFOX regimen, which is an intravenous IV in the vein regimen of both 5-FU and oxaliplatin, the ones who were treated with 3 months of chemotherapy actually did more poorly. Their survival was not as good as patients who got 6 months, right? So most patients will obviously be happier if they can get a 3-month, treatment versus a 6 months therapy treatment. So for in reviewing the medications that are available for stage 2 and stage 3, currently these are the 3 drugs that we have available. This would include 5-FU, 5-fluorouracil, which is an intravenous, as I mentioned before, preparation. The good thing about 5-FU is that its use in colorectal cancer dates back to as early as the 1950s. So it's the drug that we have the most experience with in colorectal cancer. It can be given either as a 48-hour infusion. So some of the patients who we treat at the hospital or even in private practice would be familiar with us putting the drug in an infusion ball, allowing them to go home. They can go about their business. It's hidden underneath their clothes. Nobody really knows what's going on. And they conveniently can be receiving their chemotherapy. As mentioned, it requires placement of a port A catheter, which some persons are not able to afford. The side effects would include like diarrhea. The blood cell counts have to be monitored because those can fall. Capecitabine is a tablet. As I mentioned before, it is a prodrug to 5-fluorouracil. And the good thing about capecitabine being a tablet is that, of course, you would need a porte catheter for administration. Just to go back to 5FU, you can get bolus doses, but then again, patients, a tablet is maybe more convenient for some. So it's usually taken on a two-week schedule. You take it for 2 weeks and you get a 1-week break. Usually well tolerated. As I said, both of these drugs, they do not cause, all these 3 drugs are not associated with hair loss or alopecia. Certainly, one of the main things that patients or concerns that patients will have will include the skin changes. You will have some darkening of the skin. Most patients will have darkening of the skin. Diarrhea is also prominent, but of course, we can recommend anti-motility agents such as Imodium loperamide, and cytopenias or the low blood counts are also a concern. Oxaliplatin, as I mentioned before, is given intravenously. It's usually 2-hour infusion, so you would not need any admission for that. And the main side effect that we are worried about or concerned about is neuropathy, which can be long-standing. So that was for, in terms of the discussions that we would really have with our patients with early stage colorectal cancer. But as I mentioned before, about a quarter of our patients or even more will present with stage 4 colorectal cancer. And so for these patients, and the early stage people even convert a number of them to stage 4 colorectal cancer. It's important again that the discussion will include from the oncologist the goals of treatment, and for a small subset of these patients, some may be cured. So the treatment goals for our stage 4 colorectal cancer patients would really be more so prolonging their survival, their overall survival, maintaining their quality of life, and as I said before, converting some patients who would, in the past be considered non-curable to actually become curable with metastasectomy, which Dr. Plummer alluded to in terms of resecting lung and liver lesions and based on their disease burden. So the median overall survival for patients with stage 4 colorectal cancer prior to the advent of any chemotherapeutic drugs or targeted agents would be about 5 to 6 months. And this is with best supportive care. With the advent of chemotherapy and other adjuvant therapy, certainly when 5FU was discovered and treatment started with it, which it was the main treatment for many years, the overall survival of patients improved from the 5 to 6 months to 10 to 12 months. It doubled. Of course, that was not enough. And that's why I like the field of oncology. We are always pushing. Research is always being done to see how best can we improve on the care that we have for the patient. So irinotecan and oxaliplatin, those chemotherapeutic drugs were then added some years after, and it showed that the survival for patients with stage 4 colorectal cancer improved up to 20 months. Then there were biological therapies, the targeted therapies that were added that pushed survival, median overall survival to up to 24 months. And it's important to understand that when we speak about the median overall survival, that's just half of the population. So 1/2 would be below that 2-year mark, and there are people who will be living beyond that 2-year mark. So stage 4 colorectal cancer, in terms of what your oncologist will say to you, in terms of first and second line chemotherapy, we will speak of using combination chemotherapy such as the same 5FU, it's always in the mix, and capecitabine, along with oxaliplatin, or so you'd end up with regimens Folfox, Zelox, or Capox, the same thing, Zeloda, capecitabine. One is just the trade name that is used. Folfiri and Zeliri, again, just by the use of irinotecan, which we don't use in stages 2 or 3, but certainly stage 4, a combination of that with 5FU or the capecitabine we will call those combinations FOLFIRI. So currently, there are about 5 cytotoxic drugs that we use for stage 4 colorectal cancer. I've mentioned 5-FU capecitabine a few times, and oxaliplatin. Irinotecan is also one drug that is used in combination, and this is the newest cytotoxic agent that we have for in terms of chemotherapy, and that would be the trifluridine tipiracil combination drug, also known as TAS-102 or Lonsurf. This is usually used in patients who, as third line, who have already been exposed to a combination with oxaliplatin or a combination with irinotecan, and who have had targeted therapy in terms of anti-VEGF therapy, which I will speak to later, and also EGFR therapy. So for your patients, and some are very well read, they will ask in terms of, they like figures. What, when you say that chemotherapy will help me, or a combination chemotherapy regimen will make a difference, what numbers are we talking about? So when you look at just using single agent 5-FU or just capecitabine, you'll find that a combination regimen by adding an IV drug like oxaliplatin, that you can double the response rate, so from 22% to 50%. You can also improve their progression-free survival, which is the time, from you've started treatment to you noticing that the disease is worsening from 6.2 months to 9 months, all right? And not much difference in terms of statistical significance in the overall survival. Again, this is still reflected in the combination regimen with the FOLFIRI versus the single agent 5-FU, where you have a better response rate, increasing their progression-free survival. And when you compare both the Xelox or Folfox, there is no real difference in those two. So either of them can be used. Again, capecitabine or 5-FU, if that is the only option for patients who may not be able to tolerate the combination chemotherapy drugs, their survival, PFS benefit, and overall survival benefit, those are similar, even though in this study, the capecitabine had a greater response rate than the IV 5-FU. I mentioned this drug before, previously, that it is the newest chemotherapeutic drug that we have in terms of our armamentarium for patients with stage 4 colorectal cancer. It's an oral drug, so again, very convenient for patients. And it works by essentially inhibiting DNA synthesis in the cancer cell and resulting in cancer cell death. So patients would have been exposed to greater or equal to 2 prior lines of chemotherapy or colon cancer treatment. And in terms of the study or the trial that showed that it improved survival, the RECOURSE trial was what showed that for patients who, these are patients who are heavily pretreated, there was an improvement of about almost 2 months with the use, in terms of median overall survival, with the use of this chemotherapy tablet. So targeted therapy is where we are now in cancer care. Chemotherapy was almost like the introduction to what we can offer patients. So targeted therapy since 2004, with the approval of certain targeted drugs, we have had a number of newer agents being added to our options for treating patients with stage 4 colorectal cancer. So in 2004, we had cetuximab and bevacizumab being recommended. Cetuximab, affects, I will go into how it works, but these will target certain signaling pathways in the cancer cell that they would need to grow and survive. And by exploiting or blocking a lot of these pathways, then we are able to induce cancer cell death. Anti-VEGF agents, bevacizumab which is, locally available, these agents affect the growth, blood vessel growth to the tumor cells. Of course, if you, affect or interrupt the blood supply to the cancer cells, then you can essentially starve them from the nutrients that they would need and induce cancer cell death. So currently, all these agents are targeted drugs that are approved for patients with stage 4 colorectal cancer. There are about 14 of them currently approved at different lines of treatment. Locally available, we have the bevacizumab. I know regorafenib. I've been in contact with companies to get that. Pembrolizumab, we have that locally available. Some of the other drugs, certainly pertuzumab, trastuzumab, they are also locally available. And whatever it is that, most of the companies that operate here, even if it's not readily available here, they are willing to get special orders and we can have the drug imported. So how do targeted drugs work? Specifically now, the EGFR inhibitors, there are 2 drugs that are currently approved for use in stage 4 colorectal cancer. And question would be, what is EGFR? And essentially, it's a receptor that is on the cell, right? And it's a member of the HER2 family. It is overexpressed in colorectal cancer, but what you will find is that once there is binding of the ligand to the EGFR on the cell, that, as I said before, there are pathways in the cell that will be activated that say to the cell, you need to grow, survive, etc. And it promotes then cell growth and survival. And so this is just a picture showing the EGFR target on the cell. It's a transmembrane receptor. And once you have binding of the ligand to the EGFR, then all these downstream cellular pathways are activated that will tell the cell to survive, to spread in terms of metastasize. It's important in blood vessel formation, which is what angiogenesis is, proliferation, invasion, etc. So it would make sense that if we were able to block the activation of this receptor or this target, then we will induce cell death. So anti-EGFR therapies, most of their monoclonal antibodies, they are available as combination with chemotherapy drugs in both the first and second line setting. What is important to note is that once your oncologist is having this discussion with you about these therapies, they should send the tumor tissue for testing for the presence of mutation, specifically the RAS mutation, and also for the presence of BRAF mutation. About 40% of colorectal cancers will have a mutation in the RAS gene. And this is important because, as I showed before, this is RAS. And if you are using a drug here, an EGFR inhibitor, and this already is mutated, it's not the wild type, it's not the normal RAS gene or protein, then when you give a drug here, then this will not work because this mutated RAS protein will already be activating the downstream pathways in the cell. So you won't be doing the patient any good in giving them that drug. It won't work. So if anti-EGFR therapies will be recommended for a patient, all the patients must have, as I said before, RAS mutation testing. Once there is a presence of that change or mutation in that protein or gene, then we would not be able to recommend these drugs. And it also holds for if there is a BRAF mutation. So the current NCCN guidelines recommend that you should do RAS mutation testing for, well, that EGFR therapies be given only for patients with RAS unmutated or wild type tumors and for only left-sided tumors only. And at this point, I'll say something on the sidedness of the tumor. Right-sided colorectal cancer is actually somewhat behaves differently from left-sided colon cancer. in that we find that patients with right-sided tumors do more poorly than patients with left-sided tumors. They also respond differently to treatment. Right-sided tumors have been found to have a higher incidence of RAS mutation. They also usually have a higher incidence of having microsatellite instability high tumors, and studies have shown that they do not derive benefit from these anti-EGFR therapies. Certainly, they do more poorly with these anti-EGFR therapies, which is why there's a restriction on who should get these therapies, certainly the left-sided tumors. For the right-sided tumors, for the oncologist, we would more opt to recommend like a bevacizumab, which is also a targeted therapy that works by affecting the blood vessel supply or growth to the tumor along with chemotherapy. So again, as I always tell my patients, whatever recommendations we make is usually because we have research in support of that drug. And so for some of these anti-EGFR therapy, we can see that the response rate with combination with chemotherapy is more improved than by chemotherapy use alone. There are also studies that looked at whether it would be better to use a medication, a targeted drug with chemotherapy that affects the blood supply, which is what bevacizumab does, as opposed to using the anti-EGFR drug. And again, both would have very good response rate. And for patients who have the RAS wild type or the unmutated phenotype, we find that the anti-EGFR therapies, cetuximab, panitumumab, they work better. And as I alluded to before, you have to consider too, or the oncologist will have a discussion too about the side of the tumor and what options you will recommend. So vascular endothelial growth factor is very important in terms of blood vessel growth and formation. And it holds for your normal cells, and it also holds for cancer cells. So cancer cells will make or secrete vascular endothelial growth factor A. And there are other ones like B, C, D, and placental growth factor. And what these will do, they will bind to the respective targets or receptors on the cancers, on the cells, and in terms of the endothelial cells, epithelial cells, and induce blood vessel formation. So obviously, if this is what is happening, then potentially if you make targets to medication or antibodies to target the endothelial growth factor proteins or even the receptors, then you can inhibit or affect tumor blood vessel growth and supply. And this is what all these drugs essentially will do. Currently, in terms of first-line recommendation for patients with stage 4 colorectal cancer, bevacizumab, which is locally available, is one that will target VEGF-A, and it will then interfere with the blood vessel growth or supply to the tumor. Aflibercept is also another option, more so in the second-line treatment for patients, as it is like a decoy VEGF receptor. Then it would allow for your VEGF-A, those soluble proteins or ligands, to bind to it instead of the VEGF receptor on the epithelial or endothelial cells, and so will also interfere with the blood vessel formation and growth. So this is just a picture showing how the aflibercept works. It's like a VEGF trap or receptor that binds to VEGF-A and VEGF-B, and then the bevacizumab would bind to also the VEGF-A and prevent it from binding to the receptors on the cell surface. Again, everything is guided by research or studies. And so just quickly to show that the response rate with the use of these anti-angiogenic agents for stage 4 colorectal cancer patients is far more improved and statistically significant than with just chemotherapy alone, 45% versus 35% for that one study. And for the aflibercept, which I had mentioned, again, the response rate of almost 20% to 11%. Some studies have even shown a higher response rate with the use of this tablet, and this translates to in terms of an improvement in the progression-free survival, how long we will see any worsening of your condition from the time of treatment. Regorafenib, as I said, this can be imported into the country. It is a tablet, and it inhibits a number of these kinases that would be involved in terms of cell signaling. And this was confirmed in to be beneficial in patients with stage 4 colorectal cancer in the correct trial that compared regorafenib versus placebo. And as I said before, these are patients who would have gone to 1 or 2 lines of chemotherapy or therapy with chemotherapy and other targeted drugs, and so they're heavily treated patients. But there was an improvement in the overall survival. In the naked eye, it would be okay, just a month, or a month and a half. That's pretty small. But again, this is just for half of the population of patients who were exposed, and these are patients who have had, other treatments before. Half of them do survive for longer. So this again is just a representation or a picture showing how all these different medications will work. Bevacizumab targeting the VEGF, the aflibercept acting as a decoy to the decoy receptor to the VEGF, affecting blood vessel growth and formation, and the panitumumab and cetuximab affecting the EGFR receptor on the cancer cell. The ultimate thing is downstream in terms of cellular targets to prevent growth and survival. So the newest therapy that we'll have in terms of stage 4 colorectal cancer patients, and discussion to be had with the patients, is immunotherapy. And, a patient may ask, what is immunotherapy? Certainly these drugs are advertised on their television all the time. And they may ask what it is. It's essentially exploiting your immune system, your own immune system, to target and kill cancer cells. Cancer cells are somewhat sophisticated. I mean, they do have this propensity for longevity, immortality, and so they use various mechanisms to escape the immune system. Central to that is that they can downregulate the immune system and so prevent their removal by your own immune system. So there are drugs that have been developed that will restore how your immune surveillance or how well your immune system functions. And this is what these 2 drugs, pembrolizumab and nivolumab, which are the immunotherapy drugs that are approved for stage 4 colorectal cancer. Nivolumab can be used with ipilimumab. But what they do here, as you can see, as some would have known from biology class or even from medical class of whatever kind, that T cells are very important in terms of immune surveillance and removing foreign antigens from your body. So the T cells are always essentially on the prowl, checking for self and non-self antigens. And naturally, if they come into contact with a tumor cell that would be perceived to be foreign, then they would remove that cancer cell from the patient's body. But what these cancer cells have done is that they are able to downregulate these the T cells, whether by producing this programmed death ligand 1 molecule here that will bind to the programmed death ligand 1 receptor, or programmed death ligand 1 receptor on the T cell, and in so doing can cause T cell death or apoptosis, or even T cell anergy, meaning that the T cell will just passing by and not actually recognize that these are foreign and need to be removed by the immune system. And so what these drugs that are used in terms of the immune system or immunotherapy will do is that they will either block this PD-1 ligand on the cancer cell, preventing it from then causing T-cell anergy or death or apoptosis, or they will bind to block the PD-1 receptor on the T cell. And what this allows is for restoration of the T cell function and also your immune surveillance. So these two drugs, pembrolizumab and nivolumab plus or minus ipilimumab, they are recommended for stage 4 colorectal cancer patients. Unfortunately, at this point, they're only indicated for patients who have microsatellite instability high tumors or tumors where there is deficiency of the mismatch repair protein. Even though the slide says people who have had greater than or equal to 2 prior lines of therapy, that was more so when the drugs were first approved. In the current NCCN guidelines, they can be considered even as first-line therapies for patients who have tumors that are deficient in these mismatch repair proteins, which has been extensively mentioned during this symposium, or have microsatellite instability high tumor. So it goes back again to the recommendation that all patients should have their tumor tested for the presence of these mismatch repair proteins. Good response rate with this drug, upwards of 40%, and the duration of response was also sustained. For some patients was not even reached. Again, nivolumab plus or minus ipilimumab is also a recommendation. Pembrolizumab, let me just go back. As I said, it is available locally, but it is costly. Looking at for some, in terms of cost, $1 million per treatment. So even though they're available, we understand that cost is a big issue, which I will mention at the end. Nivolumab again has a good response rate, and this translates into also a survival benefit. There are other targeted agents that can be used, and the oncologist will discuss this with the patient. What I mentioned before would have been the more common options that we would choose within first line, second line, third line, etc. Then we come to finally best supportive care. Not all patients will be good candidates for chemotherapy or targeted treatment, and this is something that as an oncologist we sometimes have to be able to decide and discuss with the patients, because some patients, nobody wants to die. All of us would like to live forever, but that is not our reality. And for some patients, giving them chemotherapy or targeted treatment will actually be worse, less of a benefit to them. Certainly, I do tell my patients that choosing who should get treatment is one of the ways we can reduce the stigma that patients, or the statement that patients are strangers or neighbors, or even people who have never been treated with any kind of cancer treatment, that they have saying that chemotherapy or cancer treatment will kill you. And choosing who gets treatment is one of the ways to do that. So for some patients who we cannot give treatment, we do try our best to make them alleviate their pain. For patients who have any kind of bleeding or obstruction, the surgeons would of course perform their surgeries on them with the diversions, etc., to help with their symptom relief. Some people may benefit from palliative radiation therapy. Right. And as I said, I would mention, and this is a discussion that you cannot avoid as an oncologist, what we're going to be saying to the patients, we have to discuss cost. So thankfully, in the public hospitals where we offer medical oncology care, most of the the first line chemotherapy drugs, and certainly what we would need for stage 2 and stage 3 colorectal cancers, the capecitabine, the 5-fluorouracil, the oxaliplatin. Those drugs are available, and they are essentially free of cost because healthcare is free. Of course, it all depends on our stocks and us having it for the patients. And so for most of the patients who would have stage 2, stage 3, and as a first line treatment for stage 4, we do have those in the public system available for them. For patients who get private care, they would know that they have to pay for these drugs, and it can be costly. Some health insurance will help, but again, it is costly. For patients with stage 4, all these wonderful treatments that I did speak of, they are even more costly, right? Some of the other chemotherapeutic drugs, they have to actually pay for them. And so cost gets very real in the discussion, and it's something that we have to speak to our patients about. So we are not where we need to be, but I think we are still somewhere in terms of what we offer to patients, and hopefully one day we can get to where some of these other newer drugs, certainly the bevacizumab, I think, and the irinotecan should be medications covered and offered by our healthcare system. So with that, I thank you for your attention. Summary: chemotherapy, again, it's not the only treatment for our colon cancer patients. The discussion with your oncologist should include all the options, especially for your stage 4 patients, and side effects and costs are factors to discuss. Thank you very much.
I'm sure a lot of us are more informed at this point in having that discussion. Realize it was a broad area, and we did our best to give us as much as we could absorb at this point. Excellent presentation. At this point, we're going to invite Dr. Milton Harry to present on the topic of stents versus surgical options in complicated colon cancer. Dr. Harry, who's a colleague of mine here at the Corner Regional Hospital, is a consultant general surgeon with an area of specialization in general and laparoscopic surgery. It is laparoscopic and bariatric fellowship in the University of Toronto, Canada. In his biography, although he listed it under miscellaneous, I think it's very important information. Dr. Harry is married to one wife and has 3 children, a proud father of 2 girls and a boy. So that said, Dr. Harry, the floor is yours, sir.
Thanks for that introduction, Dr. Longmore. I too like to echo the sentiments of excellent presentations so far. So I'd like to thank the organizers of this meeting for inviting me to speak. I'm just going to go ahead and share my screen now. So the topic I'll be speaking on is obstructing colon cancer. I will be looking at intervention, stent versus surgery. Over the next few minutes, I'll provide some background information related to the topic that I was speaking on, and then I'll provide the advantages and disadvantages associated with these procedures. Then I'll look at the evidence associated with stents and surgery, and then I'll conclude. As we practice evidence-based surgery and medicine in general, then we need to know where the evidence lies. So we all know, having heard all the presentations so far, that colorectal cancer is a significant cancer here in Jamaica and internationally. Our local registry reported incidence in females about 13 per 100,000, and for males up to 17 per 100,000. And this is actually an increase. Males and females were equal for some time. The worldwide incidence of these cancers presenting with obstruction is up to 30% internationally. And the majority of these cases that present with obstruction will be on the left side, up to 70%. And when I'm speaking about left side, I'm speaking about from the splenic flexure down to the rectosigmoid junction. All local incidence of those patients presenting with obstruction is unknown. However, we know that it is significant. Having been practicing, we know that we see these cases from time to time. So it is significant in our population. Just to mention, there's some broad areas that we need to bear in mind when we're treating patients with cancer. And looking at colorectal cancer in particular, we need to see if our intervention is for curative intent or is it merely palliation. We need to look at safety issues associated with our intervention. So we need to look at morbidity and mortality. And then there are oncological concerns, right? In terms of how we do our surgery, again, in sticking to oncological principles, and then looking at tumor outcome, looking at tumor recurrence as well as survival. And then a big issue that we often don't speak about is quality of life. That's very important when we're treating a patient. How do we impact their quality of life? So historically, surgery was the only treatment option available to those patients who present with colorectal cancer causing obstruction. It wasn't until in the 1990s, to be specific, maybe 1991, when Dr. Domoto, a Japanese doctor, he was encouraged by the use of stents in other areas. He started to implement these stents in his practice as a palliative measure for those patients who are not candidate for surgery. Since then, these stents have been extended to those patients who have curable obstructing colorectal cancer, and this is used as a bridge to surgery. Our reality here in Jamaica, at least at Corner Regional Hospital where I work, we still only have surgery available to us. I'm not sure if with the opening of the new interventional radiology center at university, if that reality has changed. But here at Cornwall, we still only offer surgery to these patients. There's at least half a dozen different types of stents available on the market. And when we see a number of different devices being available, we know that the ideal device might still be somewhere in the future. They are, however, divided into two types. There are the uncoated or the bare stents, and then there are the coated or covered stents, in which there is an impermeable membrane that coating the stents. There are reports from meta-analysis comparing the covered or the bare versus the bare stents, and there's no difference in terms of the success rate of placing these stents. Both technical and clinical success rates were similar, and the complication rates are similar as well. The drawback with the bare stents is that there's significantly higher growth of tumor into these stents. And this will bear impact in that these patients can become obstructed later on because of tumor ingrowth. There's also a lower migration rate, which is an advantage with the bare stents. The smaller diameter stent, those less than 24 millimeter, they are associated with a higher rate of migrations. And we'll look a little bit more at these. So the fundamental reason driving the growing interest in stent placement is that it converts an emergency operation into an elective surgery or a semi-elective surgery, hence reducing the perioperative morbidity and mortality. The drawback with it is that it remains, there are some concerns, oncological concerns still remain in the current literature. And we'll have a look at where we are with this. It was in 2014 when the European Society of Gastrointestinal Endoscopy came out with guidelines regarding the use of stent placement. And they recommend that it should not be used for patients in a prophylactic setting. So those are patients who sometimes we're doing a colonoscopy and we're unable to pass these lesions. So we say it's an obstructed lesion. But clinically the patient is not obstructed. Then these patients should not be offered stents. It should only be offered in those patients who have both clinical and imaging evidence of large bowel obstruction. This recommendation was strong, however, it was based on low quality evidence, and we'll see why later. Regarding the use of stents as a bridge to elective surgery, so these are no patients where we are intervening for curative intent. It was not recommended. And remember, we're looking at 2014 evidence here. They strongly recommended this, and they thought it was based on high quality evidence. They only recommended the use in 2014 for those patients who were at high risk for postoperative death, such as those patients who are elderly, above 70, and have a high ASA score. Again, this was weekly recommendation based on low quality evidence. So let's look at stents, what these are. Right? The advantages associated with colonic stents. As I say, it's lower the rate of emergency surgery, hence lowering morbidity and mortality. There's also a lower incidence of colostomy creation. As we know, colostomy, it's associated with significant quality of life issues. I can recall in my short practice so far, there was a guy who had a temporary colostomy, and this guy felt so hopeless. He thought he couldn't survive living with this colostomy, and he attempted suicide because of the colostomy. So there are significant quality of life issues with it. So hence, colonic stents lower the incidence of this. It also potentially converts an open surgery to a laparoscopic surgery. And we all know all the added benefits of having laparoscopic surgery. Less painful, the return to activity quicker. It looks better, right? The cosmesis is a big issue, and you leave hospital earlier. The disadvantages of colonic stents, there's a failure rate associated with it. In high volume centers, it's successful in over 90% of cases. And it's believed that we need at least 20 cases to gain proficiency in placing these stents. Up to 12% of patients, the stent will migrate. And as was mentioned earlier, expense is always an issue, and these stents are expensive. And we'll look more about at the oncological safety of these stents. There's also a 4% reported risk of perforation in high volume centers. And what we know about perforation and cancer treatment, one study came out of the Dutch stenting 2 trial, where Slotak et al. Did a subgroup analysis of these patients who had perforation. And what they realized is that over 80% of patients who develop a recurrence occurred in the perforation group, as compared to 40% for those who did not have a perforation. So we know if you perforate a tumor, there's a higher chance of it recurring. When they looked at 4-year disease-free survival, none of the patients who had perforation was in that group, whereas 45% of those without perforation had that. So looking now at surgery, the advantages of surgery, we can resect the tumor at the same time, and diversion can be done if we're not able to resect. The disadvantages, as we mentioned, there's a high morbidity and mortality associated with emergency surgery. Up to 50% morbidity reported, and up to 30% mortality. And this is compared to a 6% maximal mortality in those patients who we operate on electively. There's also a high incidence of stoma creation, with 2 out of 3 patients that we operate on emergently will have a colostomy created. In those patients where we try not to give a colostomy, so we do primary anastomosis, the leak rate is significant. So it's associated with a high incidence of anastomotic leak. There's a randomized controlled trial that came out in 2011 by Alcantara et al. And this study actually was stopped because of a high anastomotic leak rate. What they were doing is that the patients were randomized to stent placement, or they would have emergency surgery where an intraoperative colonic lavage would have been done, and then the patient would have had primary anastomosis. And leak rates of up to 30% were reported. Hence, it wasn't ethical for them to continue, and this study was stopped. We know we're speaking to a mixed audience here. So these patients who present with clinical signs of obstruction, so those patients who are vomiting, colicky abdominal pain, abdominal distension, and unable to pass wind, flatus, or stool, then these patients are clinically obstructed. They would have gone on to have their X-ray, which would have shown some evidence of large bowel obstruction. And then the next ideal test to do would be a contrast CT scan. I know Dr. Grant had mentioned about this. It's very sensitive and specific, both in telling us the cause of the obstruction and the level of the obstruction. So let's look at the palliative setting. So these are patients that we're not able to cure. So we're doing it as a palliation to alleviate the symptoms that they're having. There's evidence from systemic review and meta-analysis, including 4 randomized controlled trials. And they concluded that colonic stent placement may be an alternative to surgery with the added advantages of an early hospital discharge and a lower rate of permanent colostomies. The European Society of Gastrointestinal Endoscopy actually came up with guidelines that recommend colonic stenting as a preferred treatment for those patients in the palliative setting. And this is strongly recommended based on high quality evidence. So no issues there. Don't try to read this slide that's projected there. I'll point out what I want us to look at there. In 2014, when the European Society of Gastrointestinal Endoscopy came up with their guidelines, their information that they had was based on 6 randomized controlled trials, 3 of which had to be stopped, 2, one here by Perlet et al. In 2011 and Van Hoof et al. In 2011. Both had to be stopped prematurely because of high stent perforation rate. And we know perforation associated with higher recurrences and disease, survival issues. Right? So these studies were stopped. The incidences were reported at 7 and 12% respectively. The other study that was stopped was the one by Alcantara et al. With the high anastomotic leak rate, which I mentioned before. So in response to this recommendation in 2014, the Japan Colonic Stent Safe Procedure Research Group's comment was that they believe that these recommendations were premature and they should wait on more high quality evidence to come up with such conclusion. We know that stents were started out in Japan, and that's where they're the leaders in stent placement right now. So as the evidence progressed, in 2017, the largest randomized control trial was published, and this included 115 patients. One thing I like about this study is that the surgeons weren't randomized to doing any particular procedure. And of note, the vast majority, well, up to 33% of patients would have gotten a Hartmann's procedure. And most surgeons practicing, I think that's where they would lead for these patients. This surgery looked at primary outcomes the primary outcome that it looked at was overall morbidity within 60 days after surgery. And then secondary outcome was that of oncological outcomes at 3 years. They concluded that the overall morbidity was equivalent, right? So stent or surgery was equivalent. And there was no difference in the oncological outcomes at a mean follow-up of 3 years. However, there was a marked reduction in the incidence of colostomy creation. Hence, they believe that when stent, when performing expert hands, is a viable endoscopic approach. These authors' opinion was that the current guidelines should be reconsidered regarding the use of stent for those patients who needs, who might have surgery as a curative intent, at least in centers where there's a high volume of doing this procedure. So as the evidence progressed, in 2019, a meta-analysis looking at all 7 randomized controlled trials came out. And in total, there was 448 patients. All of these, the time for stent placement to surgery ranged from anywhere from 5 to 14 days. Looking at this, 4 of the studies were from a single center and 3 were from multi-center. And of note, the largest randomized controlled trial is a part of this meta-analysis. And all 7 of them reported on short-term outcomes. 5 of the 7 reported on long-term outcomes, and this is at 3 years. Looking at the results from this meta-analysis, stents had a higher incidence of systemic recurrence, with figures reported 25% for stent and 15%, and this was statistically significant. In terms of local regional recurrence, it was equivalent. So they concluded that stent provided a favorable short-term outcome by reducing the overall complications, and the 30-day mortality rate of stent was comparable to emergency surgery. However, when you look at long-term outcomes, stents were associated with a higher incidence of systemic and overall recurrence. However, disease survival wasn't impacted. So they believe that the short-term advantages of stent should be weighed against the potential long-term oncologic concerns. So in 2020, the European Society of Gastrointestinal Endoscopy, they updated their guidelines. And what are they saying now? Stents are still not recommended as a prophylactic measure, and we can see why. If we do perforate, then these patients have a poorer outcome, to say, higher recurrences and decreased disease-free survival. So they should not be done as a prophylactic intervention. In terms of as a bridge to curative surgery, they believe now we should involve the patient. So we should have a shared decision-making process where we discuss the pros and the cons with our patients and then come up with a consensus as to what we do. And this recommendation was strong, and again, based on high quality evidence. And they again recommend that stents is actually the preferred modality for those patients who were doing it as a palliative means. So these are patients who are not candidates for surgery. And it was strongly recommended based on high quality evidence. So to conclude, where we are now, the use of stents for obstructing colorectal cancers in patients with curable disease remains controversial, and further high quality studies are needed. Based on our available evidence, stents is the preferred modality in the palliative setting. However, as a bridge to surgery in those with curable disease, it remains controversial, and we should have frank discussion regarding the pros and the cons. My personal view is that stents should be used in the palliative setting only at this time. And when I say palliative setting, for those patients who might have curable disease, but they're high surgical risk, then those patients should be offered stents as well. Thank you for your time, and I welcome any questions that you might have.
Okay, Dr. Harry. Excellent presentation again. Certainly a lot of food for thought regarding stenting. As you said, has remained controversial up to this point, but much appreciate the presentation at this point. Going forward, we're going to have a slight change to the program. We're going to introduce or ask our sponsors to give a word. None of this would have been possible without our sponsors. So at this point, we're going to have a word from them. Shouldn't be too long, and then we get back into our last two presentations thereafter.
Do we know what we're eating? Important information about unhealthy foods doesn't always get to us, and this can lead to wrong choices.
1 in 2 Jamaicans is either overweight or obese. Obesity increases the risk of heart disease, type 2 diabetes, and 13 types of cancer.
We have the right to know what we're eating, especially now we need clear food labels. What's in our food? Give us the facts. A message from the Heart Foundation of Jamaica, Ministry of Health and Wellness, and the National Consumers League of Jamaica.
With over 20 years in providing quality service, Apex Radiology is Jamaica's premier diagnostic facility. Our services include CT scans, nuclear medicine, ultrasounds, x-rays, and more. We have 3 easily accessible locations in the Kingston area and 1 in Ocho-Rios. With our mission to provide exceptional and affordable healthcare, Apex Radiology is a clear choice for your diagnostic needs.
Something sweet. Too many carbs. Maybe that. Maybe not. If only they had...
Snacking should be sweet and simple.
Ooh.
The delicious taste of Glucerna gives you the sweetness you crave while helping you manage your blood sugar. Glucerna, your good decision of the day. Move with strength and energy. Drinking ensure you get vitamins, minerals, and up to 30 grams of high-quality protein. Your life, your health, your Ensure.
All right. I hope everybody's still as hooked as them. Presentations are really of high standards so far. We're going to continue that trend. Right now, we're going to have Dr. Joy Callender, who is also a practitioner, consultant, nutritionist practicing also out of Montego Bay. She practices at the Doctors Hospital here in the good city of Montego Bay. Dr. Callender will be presenting on the diet and nutrition and the colon. So, Dr. Callender, we're going to ask you to come in at this point and offer your presentation.
Let me thank the Heart Foundation for sponsoring me to speak at this Jamaica Cancer Society Medical Symposium on colon cancer. It's indeed a pleasure for me to be with you. As a nutritionist, I always want to talk about diet, the foods we eat, lifestyle. It's fitting for March because March is Colorectal Cancer Awareness Month. A quick overview of what I'll be speaking about. The risk factors for colon cancer, more so the modifiable risk factors, things like age and so on, we have no control over. And then what I thought would be useful to many persons is, as part of the management of colon cancer, once there's a diagnosis, what changes, what can we do in terms of our nutrition post-surgery, during chemotherapy, radiation therapy, because these are the primary modalities of treatment, and of course, some exercise recommendations. Nutritionists always include exercise as part of our lifestyle. And then a little bit on the type of nutrition we want to avoid recurrence of colon cancer. So the modifiable risk factors are diet, obesity, weight is always important. If we have excess body fat, that's a risk factor for colon cancer. Alcohol, smoking, a sedentary lifestyle, I'll speak a little bit more about that. But particularly when it comes to diet, it would appear that a low fiber, high fat diet are 2 of the things that we want to avoid when it comes to colon cancer. The body mass index, we're all familiar with this. How do we calculate BMI? It's an approximation for the amount of fat in the body. Once we've calculated our BMI, what does it mean? So the ideal range, of course, is anywhere from 18.5 to 24.99. That's the range for a normal, healthy weight with a minimum risk for most of the chronic diseases, including colon cancer. I like this quote. Professor Servan Schreiber, a clinical professor of psychiatry and a survivor of brain cancer himself, this is his quote, and he says, "Cancer lies dormant in all of us. Our bodies are making defective cells all the time. That's how tumors are born. But our bodies are also equipped with a number of mechanisms that detect and keep such cells in check. In the West, 1 person in 4 will die of cancer, but 3 in 4 will not. And it's that 3 in 4 that we really want to focus on. People do survive colon cancer. Their defense mechanisms will hold out and they will die of other causes." Many of the recommendations that I'm going to be offering are the result of studies, data, research data collected over time. We very often don't have clinical trials when it comes to nutrition because it's not so easy when it comes to monitoring what people are doing and what people are eating. It's clear that good nutrition affects many aspects of health, including the risk for colon cancer. Some studies demonstrate conflicting results. Therefore, the advice and guidelines given here are based on the review of many studies and on the findings from meta-analyses. Epi data often demonstrate that an increased risk of a particular food appears to increase or decrease the risk of colon cancer. Also, some foods appear to contain beneficial compounds that can actually decrease the growth of cancer cells. This slide gives us a pretty good idea of what a balanced immune system should look like. Cancer is usually the result of an underreactive immune system. Some of the natural defense mechanisms that the body has and utilizes to heal itself boost the immune system, reduce the inflammatory process underlying the growth of tumors, block the growth of new blood cells, what we call angiogenesis, because it's that supply of blood that actually nourishes tumors, increase apoptosis, or the programmed death of cancer cells, and lose weight if overweight or obese. How do we boost the immune system? By making sure we have an adequate intake of antioxidants, foods high in carotenoids, for example, carrots and sweet potato, increase natural vitamin C, for example, and I've deliberately chosen some of our more Jamaican and Caribbean foods, cherries, guavas, very high in vitamin C. We often think of citrus first, the berries as well. Drinking green or white tea, which are a rich source of catechins. Increase the consumption of fresh fruits, herbs, mushrooms, and vegetables daily. Powerful anti-cancer nutrients are in the colorful fruits and vegetables that we eat, utilizing fresh herbs and the dark green leafy vegetables. Selenium is a powerful antioxidant, and I just list there some of the foods which are high in selenium. There are many other antioxidants, of course. An anti-inflammatory diet, how do we achieve that? Well, the first thing is to avoid pro-inflammatory foods. And some of those pro-inflammatory foods are sugars, high glycemic index foods, saturated fats and trans fats, red meat, and high-fat dairy products. We also want to look at or to improve our omega-3 to 6 ratio. very often we have a high omega-6 to omega-3 ratio. What we want is the reverse. So we're always looking to increase our intake of omega-3 fatty acid foods. A high sodium diet is also very pro-inflammatory. And it's not just the salt cellar, but when it comes to cancer, some of the carcinogens we know are preserved foods, pickled foods, and highly salted foods. In the reverse, an anti-inflammatory diet, that's a diet that includes lots of vegetables, fruit, and whole grains that has been associated with a decreased risk of colon and rectal cancer. Include a rainbow of colors on your plate every day. And my next slide should help to make that clear. What we want is lots of colors because those phytonutrients actually seem to help to reduce cancer. Include healthy herbs and spices, for example, ginger, turmeric, cinnamon, cloves, peppers with capsaicin, garlic, and there are always others. Include healthy fats in the diet, for example, cold pressed olive and coconut oils, avocado, nuts, and seeds. Those are what we call healthy fats. Fish and seafood, in particular oily fish, which are also a good source of the omega-3 fatty acids. And of course, there are other lean protein foods. Mushrooms seem to be in a class by themselves and really seem to be amazing in terms of dampening this chronic inflammatory process that is often a part of cancer. Teas, green tea, white tea, and or Jamaican chocolate tea. Chocolate, very important. And then we have chocolate, plain dark chocolate. So it's not usually the milk bars, the milk chocolate bars that we're all eating, but the dark chocolate. And even that should be used sparingly as a healthy sweet. There's my rainbow of colors. You're familiar with the rainbow. And the idea is that we want to include in our diet foods with all of these amazing colors. What are some of the natural anti-angiogenesis foods? Again, edible mushrooms, green tea, certain spices, dark chocolate, spices, whole soy foods, and this is thought to be very important, and cruciferous vegetables. These are some of the foods that may induce apoptosis and therefore lower the risk of cancer. Beta carotene, legumes, that underutilized food group that we call legumes or peas and beans, citrus fruits, berries, so that's things like cherries, blueberries, strawberries, herbs again, and once again, the cruciferous vegetables. Sometimes it appears that there's an overlap of certain foods, but that's because they have different contents and may act in different ways. Is there a way to prevent colon cancer? There's no sure way to prevent colon cancer. However, it is possible to reduce the risk of getting colon cancer. Manage your weight. We want to aim for our ideal body weight, and if not our ideal body weight, what I call a healthful weight. And that usually means reducing your weight by at least 20% of your original existing weight. So if you weigh 200 pounds and you get down to 180 pounds, you've made an important improvement. Exercise. Sitting and lying down appear to increase the risk of colon cancer. We become a very, very sedentary society, unfortunately. As far as our diet goes, again, increase fruits, increase vegetables, increase the use of whole grains, and reduce the use of red meats, things like lamb and pork is in a class by itself because depending on the cut of pork, it can be white meat, but in general, pork tends to be very fatty and is regarded as red meat. And again, processed meats, things like luncheon meat, bologna, those kinds of things. A lifestyle risk factor, very important, sitting. Even after accounting for exercise, formal exercise, at least one study I saw spoke to for every additional 2 hours per day of sitting, the risk of colon cancer increased by 8%. So this sedentary lifestyle, it keeps popping up and popping up. We've got to get a handle on that. What are some of the possible mechanisms? Again, back to that chronic inflammation. Weight gain, if we're not moving, we're sitting, then it's very easy to gain weight. Also, a reduction in insulin's ability to move glucose from the blood into cells. That appears to be some of the possible mechanisms for this sedentary lifestyle leading to an increase in colon cancer. Diet. So now we're moving on to the diet as part of some of our treatment modalities. Surgery is very often common when there's a diagnosis of colon cancer, whether the whole colon is removed or a portion of it. For healing and to prevent infection, good quality protein foods and an adequate calorie intake is very important. Try to have small meals. So that means eating every 2 to 3 hours of these small meals now. That tends to reduce things like nausea, helps you to digest and absorb things better. Eat foods which are easy to digest, for example, soft, moist foods, for example, soup, pudding, yogurt. Avoid gummy foods like our Jamaican hardo bread that is so loved. Avoid spicy, high-fat, and gas-producing foods. Some of those very cruciferous vegetables which are good for you are often gas-producing foods, so we have to be very careful with that. Adequate hydration is also important. What are some of the common problems during chemotherapy now, another modality for treatment? A reduced appetite may be part and parcel of the chemotherapy treatment, but let us also bear in mind that a reduced appetite is also part and parcel of having been diagnosed and having cancer. So that's very important to the management. Very often with chemotherapy, patients will describe a change in taste so that things that they would normally enjoy eating, they no longer can tolerate. There's very often nausea and vomiting. We've come a very long way, and usually the oncologists, the team, the surgeons, they usually prescribe medication to prevent nausea and vomiting. But let me also say that from a dietary perspective, again, eating small meals is important. Sometimes not eating and drinking at the same time. Things like mint and ginger as teas can very often be very helpful in helping with nausea. And then there is mucositis. This can be a debilitating complication of chemotherapy treatment, or I should just say treatment for colon cancer. There is ulceration in the mouth, sometimes leading to infection. And this is very important because if the person with colon cancer is unable to eat or unable to eat adequately, then there is often loss of weight, loss of lean body mass, and so on. So all of these things need urgent dietary intervention. And I must say that the utilization of a dietitian or a nutritionist is important in helping patients through these changes. Key tips during chemotherapy. Some of these I've already said, others not. Small meals. Avoid very hot or very cold foods. Avoid foods which are high in simple sugars, for example, sodas and carbonated drinks. Avoid foods with a high fat content. So greasy fried foods, lamb, akis, those are all foods which have a high fat content. Avoid caffeine. Caffeine is very irritating to the gut. Avoid alcohol. And observe food safety tips. The immune system is often weakened by cancer treatments. And so there is an increased susceptibility to foodborne illnesses. What are some of the tips? Use filtered or boiled water. Wash all fruits and vegetables before peeling or eating. Keep counters, kitchen counters, that is, where meal is being prepped, sanitized. Eat leftovers within 3 days. Eat no raw or rare meat or fish. No uncooked eggs should be consumed. So things like eggnog you don't want to do. Very often people want to be doing smoothies and so on, and you don't want to be utilizing uncooked or raw products. Avoid unpasteurized beverages. Continuing with the food safety tips, wash hands often. Do not eat the outer leaves of vegetables, for example, cabbage. Refrigerate all cooked perishable foods within 2 hours of preparation. Avoid uncooked veggies and no soft or mold ripened cheeses. For example, brie and camembert. Those cheeses are mold ripened. Radiation therapy, not often used for colon cancer, more so for the rectal cancers, and radiation therapy can be used either before surgery or after surgery in order to shrink tumor size. However, when it comes to nutrition, again important, true beam radiation, this is the newer cutting edge linear accelerator machines. And so the side effects are very often much less than with some of the older machines. Nevertheless, radiation therapy targets cancer cells, but can affect healthy cells as well. External beam advanced linear accelerator for radiation treatment. I actually said that before. But this type of machine can target hard to reach tumors, and it also utilizes cutting edge image technology. So again, tumors can be, really targeted, and that's much more successful. Nevertheless, radiation therapy can weaken the immune system. Of course, cancer itself often the result of a weakened immune system, and this can lead to things like lower white blood cell counts, and you can be more susceptible to infection. Now, radiation therapy is to the pelvic region, and because of its proximity, the gut, the rectum should be empty before. We want a high fiber diet so that this makes for a more effective radiation treatment. We want to ensure adequate sodium and fluid intake. Choose foods or beverages which are high in potassium. Things like potatoes, ripe banana, coconut water, these are all high potassium foods. Because if there's diarrhea, then you very often lose your electrolytes. So that's the reason for needing to pay attention to your sodium and potassium intake. Replace electrolytes if necessary. A restricted residue diet should be followed. Sometimes the BRAT diet, that's just bread, rice, applesauce, and toast. Depending on the severity of the diarrhea, then we use different diets depending on the extent of diarrhea. Oral rehydration fluids may be necessary. During radiation therapy, make foods flavorful, drink lots of fluids, avoid supplements, especially those with antioxidants. So antioxidants are important to prevent the risk factors for colon cancer, but during treatment, in the same way that antioxidants help to prevent your healthy cells from the onslaught of free radicals, we don't want the cancer cells that are being treated to be protected by the antioxidants. And that's the rationale for avoiding antioxidant supplements. Eat nutrient-dense meals, eat protein-rich foods, and there I list some of the foods which are high in protein. So there's fish, seafood, but there's also chicken, and peas and beans are also a good source of protein. Sometimes we forget that nuts and seeds are a source of protein. When we look at the Western diet, the primary components are saturated fat, refined carbohydrates, added sugars, red meat. And this represents a global shift from the more traditional diets, such as the Japanese diet and the Mediterranean diet. Those are some of the diets that we know are associated with longevity. I didn't go into Jamaica's traditional diets, but we certainly know that utilizing our grown provisions and so on, that's part of our traditional diet, lots of fruits, lots of vegetables. These diets often are high in fiber. They are based on whole plant foods, which are themselves high in antioxidants. So you can get the antioxidants from your foods. You don't necessarily need to be taking supplements in order to get them. So less animal fat, but we can get fat from other sources. Less sugar, especially the added sugars. There is sugar in the fruits and all of those other things that we should be consuming. Now, these are the food groups, the Caribbean food groups. We should all be familiar with them, the staples, the foods from animals or protein foods, fruits, veggies, legumes, fats, and sugars. Now, the food-based dietary guidelines, the Ministry of Health, Jamaica's Ministry of Health, put out food-based dietary guidelines in 2015. And these are the things that it says: eat a variety of foods from all of the food groups, variety of fruits, variety of vegetables, include the legumes, reduce salty and processed foods, reduce the intake of fats and oils, reduce the intake of sugary foods and drinks, and make physical activity a part of your daily routine. Now, all of that really fits right in with many of the things that I have been previously speaking about. And this is the picture. A picture tells or tale most effectively. And you notice the glass with water for hydration, the sense of movement for activity, and the utilization of all of the food groups. This is what your plate might look like, so that half of your plate really should be plant-based, whether it's vegetables, and we're not talking about starchy vegetables. About your quarter of your plate should be your protein foods, your foods from animals, and then the other quarter of the plate would be from our staples, our staple foods, or yams and sweet potatoes and breadfruit and those things. So in essence, a healthy Jamaican diet is a balanced diet with a regular consumption of lean protein sources, healthy and essential fats, vegetables, and complex high fiber carbohydrates. Make half of your plate vegetables and fruit. What are some of the benefits of exercise? So we're moving on from foods. Exercise reduces the risk of some cancers, and that includes colon cancer. Exercise also releases the endorphins, which are brain chemicals, which seem to elevate our mood and just in general make us feel better. It also reduces anxiety and depression. And we know that after a diagnosis of cancer of any sort, there is often some anxiety and depression. In summary, therefore, achieve your ideal or healthful weight, boost your immune system, avoid pro-inflammatory foods and known carcinogens, increase your intake of anti-inflammatory foods, follow a healthful diet associated with longevity, follow the food-based dietary guidelines for Jamaicans 2015, and I might say that many of the islands have their own food-based dietary guidelines, and be physically active. Thank you all very much. And this picture is actually of Animal Farm in Jamaica. And isn't that a wonderful way to manage stress? Thank you.
All right. Thank you, Dr. Callender, for an excellent presentation on a topic that a lot of us are faced with in our clinical approach to management of colon cancer. cancer in general, it's amazing that when we have a sit down with our patients, this is one of the things that they ask us, Doc, what can I eat? And you certainly shed and given us a lot of information to pass on. All right. Also, as a diehard chocoholic, thank you for justifying one of my pleasures. Right. Moving along, we have next another colleague of mine, Dr. Andre Williams, who will be speaking on the topic of a holistic approach to colon cancer. Dr. Williams is a consultant oncologist who practices now out of the Teshuva Wellness Center right here in the heart of Montego Bay. And he is currently going to speak, as I said, on the topic of holistic approach to colon cancer. Dr. Williams?
Hi, good morning, everyone, or good afternoon. I am so delighted and honored to have been given this opportunity to share some thoughts on the holistic approach to treating colon cancer. I want to commend the Jamaica Cancer Society for continuing to be a voice for cancer treatment, cancer screening, and the general cancer management in our country. I want to congratulate them on hosting this symposium again. And with that, I'm going to go straight into my presentation by sharing my screen here. All right, so today we're talking about the holistic approach to colorectal cancer. Let me make my screen larger. The holistic approach is going to require us to take a bit of a journey. I'm going to talk about a few things first so we can get a better idea of the schematic that I'm using to make these recommendations. So we're going to do a little bit of basic science to begin with, and then we'll go over into the rationale for my personal approach to colon cancer that I've been using for the past couple of years, obviously modifying and tweaking as we go along. So I look forward to sharing that with you today. All right, so for our outline today, what I'm going to do is start off with what seems to be a couple easy questions, but they're not as easy as they seem because it's going to require a bit of a paradigm shift. So the first question is going to be, what is cancer? The second one is, what causes cancer? And then, of course, we'll go into what does holistic treatment for colon cancer look like? And we'll talk about a brief case study so that we can get a feel for how we apply this in the management of an actual patient. All right, so our first question, what is cancer? And I know my audience is primarily medical professionals, nurses, for example, medical students, and so on, and medical doctors. And so I would not want to insult your intelligence. Obviously, there are so many different features of cancer that we can use to imply what it is. And so we can talk about uncontrolled cellular proliferation. We can talk about genetic mutations. We can talk about the DNA damage that exists. We can talk about the abnormal signal pathways that result. We can talk about the fact that the immune system has impaired immunosurveillance. We can talk about the destruction of their intercellular boundaries as the cancer begins to progress into adjacent healthy tissue. And we can go on and on with formulating an idea of what cancer is by looking at the features that are present in someone who has cancer, the features that are present on histology, the features that are present on molecular genetics, the features that are present at various angles or perspectives of evaluating a cancer cell or a piece of cancerous tissue. And so we've all been pretty much exposed to all the latest research that has emerged over the past several decades, looking at features of cancer. But I put it to you in my humble estimation that we still have not identified what cancer is. And so I'm going to dial things all the way back this morning by postulating a very tongue-in-cheek definition, which is that cancer is a disease. All right, which means that we have identified all the features of the disease. We know what happens. We know the changes that take place. We know the mutations of various genes that are present in cancer cases. But at the end of the day, I'm postulating that cancer really is just a disease. And a disease can be defined further as a dysregulation of the autonomic nervous system. If you'll allow me to go on a brief little walk down memory lane for what the autonomic nervous system really is, we recall these diagrams that we had to memorize, looking at the various innovation diagrams of the different organs of the body, the different glands, and the division between the parasympathetic system and the sympathetic system of the autonomic nervous system, or ANS. And we know about the different neurotransmitters that are released by the nerves to achieve the various responses throughout the body. The autonomic nervous system, or ANS, resides in both the central nervous system, i.e. the spinal cord and brain, and also in the peripheral nervous system as it's carried along in spinal nerves and cranial nerves. And this is not news to any of us. I just want to set the foundation again. And so the autonomic nervous system is subdivided into three components: the classical sympathetic and parasympathetic. So parasympathetic, but also the enteric nervous system becomes critical because it has been demonstrated to operate independently of the sympathetic and parasympathetic systems within the gastrointestinal tract. So some of the principles of the ANS, though, date back to the 1900s. Many of the European researchers and physiologists of the day, Pavlov, Speransky, Virchow, etc., they postulated from as early as the early 1900s that the chronic illnesses that we see, and chronic illnesses have not changed, our ability to categorize them and to describe them has changed, but the illnesses themselves have not really changed. They postulated that chronic illness is always based on dysregulation of the autonomic nervous system. And so we know that each organ in the body is innervated by the ANS, and organ health depends on this constant tone, or the autonomic tone of that organ. And that's what we call the ANS activity. And what happens as well is that each blood vessel that supplies that organ and each lymphatic vessel that's associated with the organ is also singularly innervated by the autonomic nervous system. Each motor and sensory nerve that is affiliated with that organ, if there is one associated with the organ or area of the body, those nerves are also wrapped by capillaries, microlymphatics, and venules. And these vessels are also innervated by the autonomic nervous system. So the very motor and sensory nerves themselves that supply the various areas of our body are also wrapped by the autonomic nervous system. And so the width and metabolic activity of the vessels supplying the nerves as well as supplying the organs themselves is actually determined by the autonomic nervous system activity in the area. And that's going to determine the health of the nerve and by extension, the health of the organ or tissue. So if we look at this little diagram here, just as a refresher again, we see on the arterial end towards the left, we can see blood flow coming in, supplying the tissues in the extracellular matrix with the various nutrients, oxygen, and so on. In the middle of the capillary network, we see the exchange taking place between the extracellular matrix, the intracellular fluids, and the lymphatics in this general area. Obviously, this is a microscopic area. The exchange takes place. The lymphatics take what they are supposed to take for transport away from the area. The venules begin to absorb their waste products, and those are carried away into the venules. But right in this zone here, there's a lot of exchange taking place. And remember, we said that each of these vessels is singularly supplied, densely innervated by the autonomic nervous system as well. So the width and the caliber of the vessels is affected by the autonomic nervous system. The lymphatics and the capillaries are also significantly influenced by that. And so we have quite a bit of activity happening at this microscopic level that we're not always thinking about. All right. So based on that postulate, then we can surmise that ANS dysfunction would precede the cellular and biochemical changes associated with illness. And we know this to be the case. We may not focus on it as much as we ought to, but many of the cellular changes would have been influenced by the activity or lack thereof of the autonomic nervous system. And similarly, if we can correct the ANS dysfunction or dysregulation, then the physiology of that exchange area that we just highlighted will change, and the potential for the disease to be corrected exists. One of the things that's pretty interesting is to note that each of the 4 classic signs of inflammation that we were taught about in pathology, dolor, calor, tumor, and rubor, each of them technically, if you look at them, are dependent on the neuronal activation of the autonomic nervous system. So we see it playing a role there. And so we know that almost every cellular process, therefore, could be thought to be deriving its activity from the autonomic nervous system. So one more thing to point out is the integration between the ANS and the immune system, which has now been elucidated over the past perhaps decade. We recognize that there's a highly organized communication between the autonomic nervous system, or the nervous system in general, and the immune system. And it's almost as if the two are not really differentiated by the body itself, but for academic purposes, it's always useful for us to differentiate them as we look at their different functions. But whilst the line between the two may be blurred, what we do know is between both of them, they are critical for preserving homeostasis, both in health and trying to achieve homeostasis again within the context of disease. The third thing to mention here is that autonomic nervous system integration also takes place with what we know as a limbic system. Again, these are lines of demarcation that are largely artificial for the purposes of us understanding the human body better. But we know that the limbic system and the autonomic nervous system are closely intertwined. And so mental and physical health are also going to be interrelated in what is commonly referred to as the mind-body connection. And this cannot be ignored in disease, especially in cancer, because it plays a greater role than perhaps we give it credit for. So a little bit of a refresher on the limbic system. Not that I can do much more than to show you the diagram and, and probably highlight some of the critical areas that we're all probably avoided learning too much about. So the hippocampus is shown there, cingulate gyrus, the interface between the two cerebral hemispheres being the corpus callosum. And we know we have the amygdala and other features here, the hypothalamus and mammillary bodies. Those are present. And so the autonomic nervous system also has a point of interface with the brain itself. And we know that these are the areas that are responsible or critical for the processing of emotions, for mood, and that kind of thing, amongst their other many features. And so they will influence how we interpret emotions, how the body responds to its environment as it relates to its emotions. And so the autonomic nervous system, limbic system interface becomes critical in disease as well and should not be ignored. So the last thing is that the CNS, or if you want to extrapolate the ANS, communicates with the immune system through hormonal and neural pathways as well. So this very complicated diagram shows you, again, the limbic system shown here. Let me see if I can just get my pen going. So limbic system is here. We know that several of the axes, like the HPA axis with the adrenals, they will terminate or originate within this region of the brain. You see the autonomic nervous system here influencing parasympathetic and sympathetic, having an influence on the liver here, and interestingly, influencing the development or production of cytokines, and so having an impact on the innate immune system, and differing impacts based on which section or division of the autonomic nervous system is involved. So parasympathetic produces more of the TNF alpha, the reduction, in the TNF alpha, whereas a sympathetic system can produce either an increase or a decrease. And so there's a very, very complex interplay between the autonomic nervous system, which is present throughout this diagram, although it may only have been highlighted here. We can see that the autonomic nervous system also involved in the limbic system, is critical for several complex neurohormonal interactions present in health and in disease. So, all right, so we're back to this diagram again, because we want to remember that the autonomic nervous system is impacting the arterioles as they carry things towards the point of tissue exchange, the venules as they carry materials away, and the lymphatics as they absorb proteins, produce chyle, take away the different infectious debris for processing in the various lymph nodes and so on. So this critical area within the extracellular matrix is such an important point. And one of the things that was so important for me to have learned over the past 2 years was that this diagram actually shows what happens a little bit more closely. And so what we find here is that at the level of the actual cell, we have an autonomic nerve fiber coming in here. We see the terminal parts of the axons terminating almost right up against the cellular membrane. And so we find that the sympathetic fibers don't just affect the blood vessels, but we also see them terminating right up against the membrane here within the extracellular matrix. And as a result of that, we have been able to demonstrate that the autonomic nervous system therefore exerts an impact directly on the activity of the cellular membrane. And we know that within the cellular membrane is present several ionic pumps, the potassium, sodium, ATPase pump, for example, several ion channels, several absorption channels, and several receptors that are critical for the integrity and smooth functioning of the cell. We also see the autonomic nervous fibers impacting on the immune system. These various cells shown here. We have a mast cell here for some reason. And the point I wanted to make was that the integrity of the cellular processes, though we know that the nucleus and the mitochondria are so critical for the cellular signaling and messenger signaling and the energy production and utilization of the cell, there is an overarching impact of the autonomic nervous system on the cellular functions in terms of regulating. In addition to that, substances present within the extracellular matrix based on their impact, not just on the cells, but on the autonomic nervous system itself, can also exert an effect, whether positive or negative, on the integrity of the tissues. And so this information then becomes critical in all diseases, because we know that there's a dysregulation of what the autonomic nervous system is, the stimulus that's being sent here. And regardless of whether it's cancer or otherwise, this autonomic nervous system becomes an overarching area for potential modulation and ultimately reversal of the disease where possible. And so I'm going to be looking at how we can extrapolate this now into looking at a holistic approach, not just to a colon cancer patient, but essentially to cancer in general. So I'm getting rid of my pen there. Good. So let's talk about things that can cause blocks to the autonomic nervous system. And there are physical things that can cause blocks, such as food, especially food that's heavily preserved, possibly with toxins present based on how it is stored or processed. Environmental chemicals are critical. Scars are an area that I was extensively exposed to when I trained with a German team overseas. And hormone blockers and various medications. Obviously, infections, we can see that happening right now with our pandemic, with the exaggerated response to the virus causing severe problems with the body's immune response and ultimately coagulopathies. EMF radiation and all of these things are things that we are quite aware of. And we're well aware of the fact that various factors shown here are critical in cancer and in several other diseases. What we oftentimes don't take into account, though, is the fact that if the autonomic nervous system works closely with the limbic system, then we need to bear in mind emotional/spiritual contributors to blockages of the autonomic nervous system. And we all know common emotional stressors such as lack of sleep, relationship issues, a stressful job, COVID, isolation, lockdown, it goes on and on. And negative emotions from the past emotional trauma, past abuse. One of the things that I see very commonly in my office is unforgiveness in cancer patients. Oftentimes, there's a high level of unforgiveness present in these patients. And one of the critical things is to help them to appreciate how this may have contributed to their presentation. So we're really talking about a holistic, and everybody's quite familiar with the fact that this includes not just the physical body, but also the soul and the spirit. And so we kind of showed you why this becomes critical, that the autonomic nervous system, perhaps one could argue, exists both in the body and the soul. I don't quite understand how the spirit plays a role yet. But for those of us who are people of faith, we have our own, perhaps personal beliefs about how that factors in. And now we can use that framework to get a better feel for what causes cancer within the context of what I've shared, and subsequently how we can treat cancer from a holistic perspective. So my framework for today's talk, therefore, is to suggest that all of the factors that we discussed earlier that influence the autonomic nervous system or potentially lead to dysregulation of the autonomic nervous system, if an individual has a genetic susceptibility to one or more of those factors and they are exposed to those factors, then they have the potential to cause cancer. So therefore, we understand that cancer has quite a few genetic changes that take place, and we know that these are present consistently in the same cancer each time. But I believe that there are genetic susceptibilities, and if these individuals are exposed to the particular triggers or blockages of the autonomic nervous system that they're genetically susceptible to, then they will fall victim to cancer or whatever the disease may be. And to give a quick example of that, we all know that cigarette smoking is associated with cancer, but at the same time, we've, I'm sure, met several people who have smoked for most of their life who have not succumbed to cancer, or there's been no diagnosis made. We also know people who are supposedly quite healthy, exercise fanatics, eat a very clean diet, but perhaps their emotions are not quite in order, and they have a genetic susceptibility to be overwhelmed by certain emotions, perhaps. And as a result of that, they fall victim to cancer, even though physically they were so healthy. All right. So we're going to use this framework now to extrapolate beyond just looking at cancer and to look at colon cancer. So we know the risk factors for colon cancer, and we can see some of the framework I've created showing itself here. So obviously we spoke about genetic susceptibility, and we know the risk factors for colon cancer include several hereditary syndromes, also a family history of colon cancer or particular ethnicities will also predispose one to developing colon cancer, again showing the genetic susceptibility. Age is a significant factor, and it's easy to see where as we age, the different cellular processes may not function as well. The autonomic nervous system would have been exposed to several different insults over the years, and the more insults is the more likely that it will shift into dysregulation at some point. Inflammatory bowel disease, which again doesn't occur on its own, but is usually a response to autonomic nervous system dysregulation again. Diet is an interesting one. That's almost a whole lecture on its own, because interestingly, the work of Gonzalez and his team revealed that specific diets actually have a direct impact, whether positive or negative, on the autonomic nervous system. That specific diseases are either sympathetic or parasympathetic dominant. And as a result of that, the body shifts out of balance, and we can actually use diet to shift it back into a state of balance. Alcohol and tobacco represent environmental toxins or diet, depending on how you look at it. And they have a significant factor in colon cancer and obviously on the autonomic nervous system as well. So a little diagram, I know there's surgeons amongst us. I just wanted to show the proximity of the colon to adjacent abdominal organs, in particular, the proximity, both physical proximity and also in terms of blood supply to the liver. And that's going to become important shortly as we look at the relationship between the blood supply to the left side of the colon in particular and the portal venous system and the interaction between the various parts of the bowel and the liver. Not going to go into too much detail, but just wanted to create that image. And we know the liver is densely innervated with autonomic nerve fibers, and there's also quite a bit of neurohormonal interplay taking place with the various factors involved in digestion, also glucagon and that kind of thing. Glucagon, insulin, storage of energy and that kind of thing, constantly being balancing on a knife's edge almost, heavily dependent on neurotransmitters and the work of the autonomic nervous system again. Other thing to point out about the liver is that the various aspects of detoxification are not automatic. So we know the phase 1 involves cytochrome P450 and the various chemical processes that take place. We have some intermediary metabolism taking place here, shifting it over from fat-soluble toxins to water-soluble waste. In phase 2, there's conjugation, and we know we had to learn all of these processes in biochemistry and ultimately elimination. What we oftentimes don't remember is that there are several nutrients needed for these processes to take place comfortably. And so nutrition again begins to play a significant role in the cancer patient, because the liver is going to still need these nutrients in adequate amounts if it's going to detoxify the body adequately. And if we look at what the liver has to do on a given day, the baseline liver burden involves clearance of metabolic waste, clearance of inflammatory debris, processing of food and elimination of the food contaminants. The liver also plays a role in the reticular endothelial system, so it has to help to clean pathogens and process pathogens. The clearance of bilirubin and the enterohepatic system is also something the liver is responsible for. And then finally, energy storage. And I'm sure there's probably a couple others that I need to highlight. I'm just being brief here. If we look at the baseline liver burden, though, in a cancer patient, we now need to add to that list the breakdown products of the tumor. So let's assume that the body isn't just totally ignoring the tumor, but it's actually actively trying to correct the situation. Then there's actually tumor breakdown products being formed as well, which naturally will float over to the liver by the bloodstream and need to be processed also. And then if we have a patient who is receiving chemotherapy, we then need to think about the fact that the body needs to process the chemotherapy. When it has done its job, then we still have even more tumor breakdown products being sent to the liver. And also we now have to deal with the chemotherapy drug metabolites as well. So it's quite a bit for the liver to handle, both in health and worse in disease. So our holistic approach then becomes looking at all of the factors that we've identified there and tying them up neatly into a framework that we can use to evaluate and approach each patient more or less consistently. And I know of many times we hear the word holistic, it seems a bit unscientific. It seems like it varies from person to person with no real central guidelines. But I believe that over the years, my opinion has changed where that is concerned. And I believe that there actually is a way that we can be consistent in evaluating our patients holistically. So my approach to any cancer patient, but in this case, colon cancer, is shown actually in stepwise fashion in terms of priority. So based on what I've shown just now, my number one approach in any cancer patient is to support the liver. And the reason for that is simple. If we are going to be successful in eliminating the cancer, the breakdown products are going to be sent to the liver for processing. They're going to need to be detoxified and eliminated. And so if the liver is not healthy, which it often isn't in cancer patients, then we are actually giving it more work to do and pushing the patient ever so much closer to liver failure with each intervention that we make. The second stage is to improve oxygen utilization, and we'll talk about how we do that. The third is immune system support. The fourth is to identify any unique autonomic nervous system blocks that this patient may have had, especially emotional issues, which are so common amongst cancer patients, but often overlooked by both us as physicians and also by the clients themselves. And then, in my opinion, once these have all been established, then we can discuss conventional treatment with the person as necessary. I am not against chemotherapy, surgery, or radiation in the least. I'm just of the opinion that we have to make sure that the patient is adequately prepped prior to the chemo and radiation. And as I'll share earlier, certainly in the case of colon cancer, surgery is where the surgeons can achieve surgical resection. It is a must. All right, so here's my little pyramid that I put together, with the broadest base being supporting the liver, in my opinion, followed by improving oxygen utilization, immune support, removing autonomic nervous system blocks. And then once those have been identified and put in place, I believe that patients should always be given the option for conventional therapy. And obviously, there's going to be an individualized basis. So we'll talk more on that. So in terms of supporting the liver, there are two techniques that are critical. One is diet and nutrition itself. And the second is the use of coffee enemas. So diet and nutrition are going to be critical for supporting cellular metabolism in cancer patients, because the cells, the normal healthy cells, will still need nutrients, and the body is still going to need nutrients if it's going to correct the cancer that it has formed. A plant-based diet has been shown to be ideal, certainly for solid tumors, and in this case, colon cancer. And what we're hoping to do is to reduce the burden on the liver, to reduce the burden on the intestines to absorb. So we want to develop a diet that is providing nutrients without requiring too much enzymatic work. For example, we don't want food that is too heavily processed, because the process of digestion then becomes, it requires energy rather than providing energy. So as I mentioned earlier, Dr. Gonzalez et al. Published several studies demonstrating that there actually is a direct effect of the dietary choice on the autonomic nervous system. A plant-based diet will promote a return, a parasympathetic tone, whereas an animal protein-based diet will promote sympathetic dominance. So most of the solid tumors that we deal with tend to already have the body shifting into a point where the sympathetic nervous system is actually predominantly working, meaning the autonomic nervous system is dysregulated in favor of the sympathetic side of the nervous system. And so to balance those patients, we want to offer a plant-based diet. And then for somebody who has like a lymphoma, leukemia, tend to be a lot more parasympathetic dominant, you want to offer those patients actual animal protein. So I know there's a lot of thought that a plant-based diet is appropriate for all cancers, but Dr. Gonzalez's work seems to disprove that. Coffee enemas, there has obviously been a lot of concern about their use. Some people think that they're actually just a fad, but the science is pretty strong for them. The presence of 2 salts in the coffee when administered rectally increased bile peristalsis. This is just 2 of the many features they cause. Increased bile peristalsis and repeatedly increase the activity of the enzyme glutathione S transferase, which makes the transfer of toxins from blood to bile perhaps 600-fold in some cases quicker. And as a result of that, the ability of the liver to detoxify its existing burden, as well as the burden you place on it, is multiplied 600-fold, obviously leading to a better ability to detoxify and eliminate everyday toxins, as well as new breakdown products from the cancer. Coffee enemas are only feasible when colonic resection is minimal, because we don't want to place a burden on the colon if there has been large amounts of the colon removed. And they can still be administered. However, if there's a stoma present, there's a special kit that we use to administer them via the stoma. In terms of improving oxygen utilization, at Teshuva Wellness, we use ozone treatment. And to tell you a little bit about ozone, it's a supercharged O2O3 mixture. So the volatile molecule O3 actually significantly improves antioxidant responses in the areas that it comes into contact with. So it can be safely administered in a colon cancer patient, either as a rectal insufflation or as autohemotherapy. And at a cellular level, one of the many features that ozone achieves is to restart the Krebs cycle by normalizing the NAD-NADH ratio, which is oftentimes crippled in the mitochondria of the cancer cell and the adjacent healthy cells. It also has been demonstrated to improve the efficacy of chemotherapy and radiation in patients who have it, who run it in parallel with their adjuvant efforts. In terms of immune system support, we still use the ozone because of its other benefits, and we also use a phenomenon called caloric restriction. In the case of the immune system, ozone safely increases the production of the cytokines that we had highlighted earlier. And the key thing to point out is that it does so without any side effects whatsoever. It also increases the production of NRF2, which is a cytoprotective molecule, which improves the health and integrity of the cells. And it's immunomodulatory in that it shifts the balance of Th1 to Th2 cells into a more favorable balance. Usually they're shifted one way or the other, and it shifts them back into balance. So pretty useful for cancer and the immune system in general in that regard. In terms of caloric restriction, we usually do this for about 4 weeks. We use a plant-based diet, and we restrict calories for about 4 weeks. And the objective there, it seems counterproductive in a cancer patient because you'd think that we'd want to flood them with as much nutrition as possible. But we restrict the calories because we've found that it significantly improves T-cell mediated function. It primes the immune system, and we know that immunosurveillance is impaired in cancer cells. And so it primes the immune system and makes it more feasible and more likely that the tumor will be identified and dealt with by the body's innate immune system. And some of the studies are suggesting that it may also be in part mediated through reducing prostaglandin E2. This is a critical one, clearing ANS blocks, especially emotional. Many of these patients tend to have family discord with a spouse. Many of them tend to be caring for an ill family member, again, oftentimes a spouse. And usually if there are liver mets present, there's usually a great deal of anger and resentment underlying all of this. So conventional treatment, as I mentioned, I'm not against it in any regard. And surgery is always recommended for colorectal cancer where it is surgically feasible. However, I believe that for adjuvant treatment using chemotherapy or radiation, timing and patient selection are key. We want to be looking for things like the performance status score of the patient, how likely it is that they'll be able to attend their appointments to have their chemotherapy given, how likely it is that they're going to be compliant, what's their family support, what's their ability to afford the treatments. And so a lot of these things will then play back into the other preceding factors if we're not careful, and make the patient more stressed, which makes the likelihood of a cure lower. So I'm going to end by talking about a brief case study, the details of which I'm going to be publishing soon, I hope, or at least expressing in an interview format that you can feel free to watch on the YouTube channel. Patient FS, 59-year-old female, who I met some time ago, gave a history of hypertension, for greater than 10 years, well controlled. But her type 2 diabetes was very poorly controlled. Random blood glucose, despite claiming compliance with oral hypoglycemics, was on average 20. She took her regular blood sugar readings, and that's what she was getting at home. No family history of cancer or other illnesses, no personal history of other illnesses. And she was diagnosed with stage 3 colon CA in 2017, which was completely resected. She described getting adjuvant therapy with FOLFOX6. I need to really double check that given what happened afterwards. But suffice it to say that there was no residual disease after her initial treatment. But when she was reassessed in 2019, her CEA was found to have increased. Her preoperative CEA had been increased as well, and so that triggered a search for possible recurrence, which was confirmed with multiple large lung mets scattered throughout the chest. This was actually complicated by lung abscess on the left side, I believe, requiring drainage. She was seen by her primary oncologist and placed on single-agent capecitabine. So I need to quickly elucidate that story to be more accurate, because I'm not sure if she had in fact complied with her FOLFOX6 entirely. Regardless, her CEA had improved on capecitabine, but the patient found that the side effects were unbearable. And so she reached out to our team to see if there was anything we would be able to offer her. So this is somebody who had already been exposed to conventional treatment and is now trying to see if they could get some additional help. So we use our pyramid. Again, our priority is to support the liver, even more so in her because she had been previously exposed to chemotherapy, and they were going to do it stepwise from there. Given that she had already done conventional treatment, we now need to focus on the other tiers of our support. So in terms of supporting the liver, we did restrict her calories for 4 weeks, put her on a plant-based diet, no processed foods, etc. And she did coffee enemas once daily, every single day. We offered her ozone treatment via autohemotherapy. She did that twice weekly for 6 weeks, and at the end of the 6 weeks, she was then switched to twice monthly schedule. In terms of immune system support, again, the caloric restriction and the ozone treatments were what we used for this. And in terms of clearing her ANS blocks, when I spoke with her, she gave a history of intense family discord with her husband, which led to a pretty painful separation. She interestingly had no anger or resentment. What she did have was severe grief and regret over what had happened. She felt responsible. And so I referred her for emotional counseling. We have a specific type of counseling that we recommend for these patients. And with respect to her conventional treatment, her Karnofsky score was 90%. She was unwilling to continue chemotherapy, but I still recommended that she do regular follow-up with her primary oncologist whilst we worked together so that we could have an objective assessment of her outcomes. Essentially, it boiled down to this. After 6 weeks on the therapies I outlined before, her glucose control improved considerably. She was now getting fastings of 6s and 7s, and most of her checks throughout the day had shown significant sub-10 readings. In terms of her CEA, though, that continued to rise initially. It was at 9 at 6 weeks. At 12 weeks, her glucose control was now consistently normal. Her CEA remained elevated. Her chest pains and frequent discomfort actually returned. So she started to have quite a bit of pain in the chest, which was very concerning for her. But of note, her relationship with her spouse had started to improve with the emotional counseling. At 6 months, her glucose control was still normal. The CEA was still elevated. It was 13, as I recall. And her chest pains and discomfort, however, had resolved. And she described improved energy. By this time, the side effects of the chemotherapy obviously would have worn off. So she had resolved hyperpigmentation, not attributable to our involvement, but rather just to the fact that her chemo was discontinued. At 6 months, she also had a repeat CT chest, which showed an approximately 50% reduction in the size of the lesions. And I asked her at this point to keep her mind active and her emotions controlled. I asked her to start doing a mentorship program for new patients with a similar diagnosis at the clinic, So she became a point of contact for all of these patients. She had a review at her primary oncologist, which confirmed her improvement. At 12 months, she had repeat imaging, which actually showed no residual lesions in the chest. Her CEA now plummeted to 1.5. Her LFTs, liver function tests, all normal, HB normal, and for what it's worth, she was now fully reconciled with her spouse. She's a totally changed individual. I'll place the interview on my YouTube channel and you guys can meet her. I just wanted to give the salient points here. And so in summary, my talk today has postulated that cancer represents an extreme dysfunction of the autonomic nervous system, which we know can be corrected. A holistic approach to cancer, contrary to popular belief, should never exclude conventional evaluation and or treatment. But I feel like there are different things that need to be put in place before we expose a person to the conventional treatments. Having said that, as I said before, surgery should always be performed where surgically feasible in a colon cancer patient. And I think that after the surgery has been performed, they should be properly evaluated according to the pyramid I showed. And once those things are all in order, they should always be offered conventional evaluation and or treatment. We want to evaluate all the factors that could possibly be contributing to the client's presentation so we can provide the proverbial holistic approach. You can follow me on social media. I'm always doing videos about some of these testimonials, some of my experiences, some of the things I learned when I travel overseas. I see patients across the world via Zoom, have been doing so for a while. And so I see different expressions of the same disease. And I'm always happy to share my experiences. I'm always learning, continuing to learn, and I look forward to being able to share more with you guys in the future. Those are my references, and I want to say thank you again for having me, and have a great rest of the day.
Thank you, Dr. Williams, for a very informative presentation. Certainly, I'm sure you have sparked the interest of a lot of us in this symposium regarding an approach to the management of colon cancer. Certainly an interesting alternative. At this point, we're going to entertain some questions. I'd like to congratulate all our panelists who have presented so far. Questions have been generated and most of them actually have been answered for those of us who have been following the Q&A segment of the presentations. However, I think I'd like to congratulate Ms. Letna Allen Rowe, who have certainly fielded the majority of questions. And in fact, there are at least 3 questions she has hanging. I don't know if anybody, if the panelists are seeing these questions and they would like to take them on. For those who are not seeing them, I'll just read. Number 1, why is it when persons have a lifestyle change, they oftentimes diagnosed with cancer? Case in point, a few years ago, my MD suggested to me that I was obese as I was weighing 250 pounds at the time. I went on a regimen, changed my diet, started a running and gym routine, lost 60 pounds thinking that I was lean and good, went for my annual medical routine only to be diagnosed with cancer. Is this the norm, that these diseases are hidden and surfaces after a radical change in the body? If any of our panelists can address that one first. Let me see.
My view is that it may have just been coincidental. Certainly, I don't think a healthy lifestyle is something that is negative or cancer causing. In the opposite, maybe the person at that time, in addition to changing their lifestyle, also, had better health seeking behavior. But I don't know of anything in terms of research that it would support that sort of hypothesis. Dr. Harry can, comment.
I would agree with you. It seems pretty coincidental that it happens. So I concur with what you say, really. I couldn't speak to any evidence to say otherwise.
Okay. I think Dr. Taylor, this one probably the second question probably will be directed to you as well. At what stage does the oncologist should stop chemotherapy on a cancer patient in his or her care?
Well, again, as I had mentioned in my presentation, the duration of chemotherapy or any colon cancer treatment, whether chemotherapy with targeted therapy, is all dependent on the patient's stage. So for most of the early stage colon cancer patients, we do have a cutoff time, and the treatment time ranges from 3 to 6 months of treatment. For stage 4 colon cancer patients, where the vast majority are not curable, as I mentioned before, our goals would include controlling the patient's disease, would want as much tumor shrinkage as possible. There are patients who have stage 4, and when you evaluate them after during treatment, they have such an excellent response, a complete response. So we're guided by the response of the patient. If the cancer is if the tumor is shrinking, if you have tumor in the liver, we do assessments like interval scans, CT scans, to see what your response is like. Most patients, though, there's no finite duration of treatment. It's an ongoing evaluation on how well the patient's cancer or tumor is responding, and that dictates the treatment that we give. Of course, if a patient has any untoward effects of chemotherapy, if the effects are too much, the toxic effects, or any treatment at all, then we would likely switch. So then we would recommend some other treatment for the patient. And in the end, the patient's decision is the most important. If somebody says to us, we don't want any treatment or any further treatment, then legally we have to stop. Right.
Probably geared toward Dr. Williams. Does colon cleanse help to eliminate colon cancer? If so, what is the best cleansing method to use and how often? If you have an opinion on that, sir.
All right, so very common question. I think what I've learned from my journey into the integrative space is that it's not very carefully regulated. And because people, as Dr. Taylor presented earlier, because people are often turned off by the thought of chemotherapy, for whatever reason, there's an eagerness to try and seek out simpler solutions. But I think what I've also noticed is that there have been a lot of, how do I put this nicely? There has been a lot of misrepresentation because of inadequate, people who are not necessarily exposed to the level of accurate information that we as physicians are, sometimes take advantage, whether willingly or unwillingly, of the public's eagerness to find a simple treatment. So I went around in a bit of a circle to say simply that to use a basic word like colon cleanse really doesn't accurately describe what we're referring to. And I think it's important also to state that each patient should be properly evaluated each time they present with cancer, both by the conventional docs and or a qualified professional of whatever kind, to ensure that they're not just doing something called a colon cleanse, because that has a very vague meaning. Some people give you tablets and say this will cleanse a colon. And because of what I presented earlier, we know that a colon cleanse, whatever it may be, certainly would be insufficient to treat cancer just using one simple tool. So I think we have to be so careful as physicians to be able to welcome patients' questions. This is a very good question because the information is out there, without shutting it down completely, but also to provide accurate information to inform ourselves and to identify that there is actually good research out there to document useful non-conventional methods, but these must also be properly and responsibly presented to the patient. I don't know if I made the waters more muddy or a little better.
I think you have addressed it quite well, sir. I think we can slip in one more. I see a question here that came within the chat. Prof. Plummer mentioned earlier that the recurrence of colon cancer after 5 years is high in Jamaica compared to North America. Has any research been done to identify why? If anybody can, anyone of the panelists can take this on. Why is our recurrence rate that much higher than in the North American?
Just to offer a comment, I think Prof. Plummer might still be on and be able to respond as well.
I'm actually not
but as was pointed out by a number of the presenters, it's all dependent on the stage at which it was picked up. Hence, one of the emphasis of this meeting is for us to move to more screening. So once we can pick it up early, then it can be adequately treated, and that will decrease the incidence of recurrence. But it all depends on the stage. So the later stage disease, then those will be associated with higher recurrences.
I think Prof. Plummer had also mentioned whether it is certain things that the surgeons will do in terms of their operations, whether lymph node dissection and the pathologists there, people can be understaged, and so they can be undertreated based on the findings at pathology evaluation. So if people are understaged, they may be undertreated, and that may translate into, a higher incidence of them having recurrence. So there are certain issues I think that we can address or adjust. But as Dr. Harry said, again, the later stage that you present at, then the higher the risk of you having recurrence.
Patient compliance as well is also very important. A lot of patients tend to default for one reason or the other, whether financial or emotional, psychological. But yeah, defaulting from treatment also contributes. They get their surgery, probably do one treatment, then they don't come back to the clinic till a year later until when they're symptomatic again.
And in Jamaica, that is very common. As I mentioned, everybody knows about chemotherapy, especially people who've never had it.
Okay. All right. I think we've filled. I see we're having some hands up. If there's any questions. All right. At this point, we're going to allow I think the sponsors are supposed to have another word, and then we're going to go into a vote of thanks. On my own behalf, I'd like to thank the Jamaica Cancer Society for allowing me to host and moderate this segment. Excellent presentations right throughout. It was a pleasure indeed. And I'm certainly sure that for all who attended, we believe in this conference, this symposium for the better. All right. If anybody else, well, we'll have the sponsors remark and then the vote of thanks.
Do we know what we're eating? Important information about unhealthy foods doesn't always get to us, and this can lead to wrong choices.
1 in 2 Jamaicans is either overweight or obese. Obesity increases the risk of heart disease, type 2 diabetes, and 13 types of cancer.
We have the right to know what we're eating, especially now we need clear food labels. What's in our food? Give us the facts. A message from the Heart Foundation of Jamaica, Ministry of Health and Wellness, and the National Consumers League of Jamaica.
With over 20 years in providing quality service, Apex Radiology is Jamaica's premier diagnostic facility. Our services include CT scans, nuclear medicine, ultrasounds, x-rays, and more. We have 3 easily accessible locations in the Kingston area and 1 in Ocho-Rios. With our mission to provide exceptional and affordable healthcare, Apex Radiology is a clear choice for your diagnostic needs.
Something sweet. Too many carbs. Maybe that. Maybe not. If only they had...
Snacking should be sweet and simple.
Ooh.
The delicious taste of Glucerna gives you the sweetness you crave while helping you manage your blood sugar. Glucerna, your good decision of the day.
Move with strength and energy. Drinking ensure you get vitamins, minerals, and up to 30 grams of high-quality protein. Your life, your health, your Ensure.
Good afternoon, ladies and gentlemen. The verdict is in. The symposium was an overall success. And like for all events, there are key elements that go into making an event a success. And so we say one of them is gratitude, which is a must. So to our chairman, Earl Jarrett, our outstanding moderators and presenters, Dr. Catherine Hagen, our guest speaker, Dr. Mike Mills, Professor Joseph Plummer, Dr. Nichole Grant, Dr. Jodie Taylor, Dr. Milton Harry, and Dr. Joy Callender and Dr. Williams. A big thank you to you all. Nathan Sylvester, our moderator in the first session, and Dr. Chapman Longmore. We're truly grateful for you and to you as well, Dr. Longmore, for the personal sacrifice we knew you made this afternoon. We know it has not been easy. As an NGO and not-for-profit organization, we need the support of others to achieve our mission. So we express our sincere gratitude to our sponsors and partners, the Heart Foundation of Jamaica, Apex Radiology, and Abbott Nutritional. We know that behind the scenes, the wheels turn to drive an event forward. So I take this opportunity to also thank Mr. David Miguel, our IT technical support today, Mr. Michael Leslie and Ms. Dion Thomas for being here today and also being integral in organizing the event. And of course, to our team there at Cornwall Regional Hospital, with the support of Dr. Juanette Jordan, we thank you for helping us drive this symposium that side of the island. And Dr. Mills, whose idea it was to host the first colon cancer symposium in Jamaica in 2010. We thank you, sir, because it has given birth to an extraordinary event. And finally, to all of you for sharing with us this day and supporting our efforts, we say thank you to all 222 persons who signed on and supported the symposium. And I say to our media partners, we thank you also for showing your support and for helping us in getting the word out about the awareness that is needed to spread to the Jamaican people about colon cancer. So I say on behalf of the Board of Directors, management and staff of the Jamaica Cancer Society, thank you. And may I beg you know, keep safe and follow the COVID-19 protocols by the Ministry of Health and Wellness so that we can have you join us once more on Sunday, April 25, 2021 for the Dr. Joseph St. Elmo Hall Memorial Lecture on Cervical Cancer. Dr. Troy Catcliffe of Baptist Health will be our guest presenter. Walk good and thank you.